So pretty heavy weightage as far as our subjects were concerned. Yes, 2 to 4 questions were completely bouncers. Those questions they make brand new questions from the latest edition of the textbooks. And I always recommend, if you don't have any idea about these, please don't take a chance. And it's always good to leave a couple of questions here and there which are absolutely brand new, right? If you're very lucky in the sense that you've read something and you know that answer to the brand new question well, you're looking at an extremely good rank. So anyways, friends, let's start with our discussion of the endocons paper first, right? It had more questions, so endocons paper discussion first. The first question that I have put out here is Canberra, which is your based on Radiology. You have your caries management by risk assessment. Yes, caries management by risk assessment. And the question was actually pretty commonsensical. It was not a very controversial question. He asked that what is a disease indicator here, but not a risk factor? So if you see the options, one is plaque deposition. It's a risk factor, isn't it? You have more plaque, you have more microorganisms, you have more caries. Snacking is again a risk factor. Hyposalivation is a risk factor. What is a disease indicator? Extension of caries in the dentine, right? So clinically or radiographically, if you see that caries are extending deep into the dentine, it's a disease indicator. Yes, so that's the answer. So first question, Canberra's answer is extension of caries in dentine. The second question was a clinical question, many a times discussed. I'll share the screenshot of the notes also. Class 2, you're doing a class 2 preparation in a maxillary molar. It's a deep caries. And once you've done your prep, right, you've done your initial and your final cavity prep, you realize that there's minimal dentine thickness that remains. When you say minimal, that means your RDT is less than or equal to 0.5 mm, right? Now, what do you do? What do you do in such a situation? Of course, being a clinician wherein you don't have, the examiner has not mentioned here that there is a frank pulpal exposure, right? So what are you looking at? And there are no other, there's no other mention of any other symptoms related to irreversible pulpitis or a necrotic pulp. So our job is to maintain the vitality of the pulp, right? So we are going to do an IPC. Yes, we're going to do an indirect pulp cap. And if you see here, this is a screenshot of the detailed discussions that we have, and this is a screenshot of the time-stamped notes that we give you both in hard copy and soft copy. Very clearly, we've mentioned that when your RDT is less than or equal to 0.5 mm, calcium hydroxide liner should be placed. Then you cover your dentine, yes, and obviously the examiner is pretty helping us in the sense that he has also added this option of a calcium silicate cement as a liner or / calcium hydroxide liner, and then cover the dentine. So excellent, guys. That's the answer. This is what we are supposed to do when we don't have symptoms of either necrosis or symptomatic irreversible pulpitis. We have a healthy pulp or a reversibly inflamed pulp. We're looking at saving the pulp, right? So you place a liner, you cover the dentine, and you do your restoration. If you see the other options, liner is contraindicated. Absolutely not. You do give a liner, so that's wrong. A direct application of resin-based composite, why would you do that? You do want to, form some kind of a definitive reactionary or tertiary dentine there. So you would want to give some kind of dressing like a calcium hydroxide or a calcium silicate based liner. Directly zinc phosphate cement and doing an amalgam, no. Whenever that's very clearly written in Phillips, that's many times I've told you, mentioned in another part of the dental materials part of your dental cements chapter also, that if you have RDT of less than or equal to 0.5 mm, you have to place at least a cavity varnish or preferably a calcium hydroxide liner below the base of a zinc phosphate cement, should you decide to do a direct filling gold or an amalgam restoration. So the answer is simple: class calcium silicate or calcium hydroxide liner, and then cover the dentine. Next question, guys. So that's a screenshot. Maximum interfacial stress are present in preparation with CFAT. Oh, so many times you have configuration factors, so many times in our discussions and in our lectures and in the notes, we've made this, diagram with Summit and Robbins, as well as our Sturdivant, that we have these 5 to 1.5 and 0.2 as the C factor values. 5 is the value for class 1 prep and class 5 prep, isn't it? And more is the C factor, more is the interfacial stress, more is the polymerization shrinkage stresses, more is the interfacial stress. So the answer is pretty simple, 5. Yes. Avulsion corresponds to what classification by Ellis and Davies? Yes, very simple. Again, the answer, of course, is Ellis type 5 fracture. We discussed this in our class. It's mentioned in the notes. That's the time-stamped notes screenshot that we have. If you see here very clearly, we have mentioned Ellis class 5 avulsion injury. Yes, you have to memorize all the 9 and you have to be very precise with it, right? Isn't it? The examiner wants us to memorize things also. Next question, guys. Again, a typical question, Ellis class 2 fracture. So there is dentine exposure, but no pulp exposure, right? In maxillary central incisor of an 8-year-old child, right? So you have a permanent tooth in an 8-year-old child. Most likely it's a permanent tooth. Restoration should be done with. Now, this is a trick question. Why? Because you can do, ideally, you don't have a pulp exposure. You're not dealing with a pulpotomy or whatever, right? The examiner has not mentioned that the tooth has turned non-vital. So we are staying optimistic. We are saying that, okay, fine, it's just a dentine exposure. We need to restore it. Now, the thing is that both GIC and composite are given in the options. What should you go with? Why do I say it's tricky? Because when you see the latest IADT guidelines, they mention both GIC or a resin-based composite, guys, right? But if you see Cohen, it specifically mentions composite. So if I am to summarize, I would go with composite as the answer. If I were you, I would go with composite as the answer. Next question, guys. A 5-year-old child, 20 minutes back, he has suffered an avulsion injury to his maxillary central incisor. What should be done? Now, this is a trick question in the sense that, the first thing that comes to the mind is, oh, just 20 minutes. Let's quickly reimplant it. But you have to realize that the examiner is smart enough. Number one, he gives you the time, which is pretty attractive in the sense that you would quickly jump onto the option of quickly replacing it, reimplanting it. The other is 20 minutes back, yes. And the other trick here is that the other intelligence of the examiner is that the examiner clearly, very clear in clear terms, does not mention whether it's a deciduous or a permanent tooth. So you have to apply your head here. It's a 5-year-old child, guys, and he's just mentioned central incisor. So this is a primary or a deciduous tooth, and it is not supposed to be reimplanted. So guys, just forget about the other options here. Simple answer: do not reimplant. We keep telling you this. You see here in our timestamped notes, you see very clearly right at the start I mentioned at this time that deciduous tooth is never reimplanted, right? So this is again straight from the notes. In fact, practically everything is straight from our lectures, the discussions, the GTs that we keep doing regularly with you guys. Everything is from there. Next, okay. This was a very atypical question. I kind of illogical thing. You had this is an image-based question. I'll make an image here because it was just completely illogical. So the image was that you have a lower left mandibular molar. Yes, yes. It had a very big, MOD kind of radio opaque metallic kind of X-ray appearance on the X-ray. So it was typically a MOD, either an inlay or amalgam restoration, some metallic restoration. Yes. And on the X-ray, what was shown was a lot of bone loss in the furcation area and overlapping that, not inside the canal. If overlapping that, you had this kind of a double or a post kind of a thing that was there with a kind of a stopper here, right? What all other things were there on the X-ray? You could see that the pulp chamber was pretty calcified. The canals were pretty narrow. And the other thing that you could appreciate was the premolar had a full crown. Anyways, this is just all the information that was there. And he said, and the most important, the most significant thing here was that, there was gingival, there was bone loss in the furcation area. Now, you know that gingiva always attaches to the bone, right? So if there's bone loss, the gingiva is also going to go down. So the question was, which structure is exposed following the bone loss? And they had mentioned all the 4 tooth structures, that is cementum, dentine, enamel, and pulp, right? So the answer was typically, you've attachment loss at the furcation, you have root exposure, you don't have pulpal exposure there that is being seen. So the answer in all likelihood was cementum, right? So the answer by common sense was cementum. If I were you, I would mark that. Then you have radix paramolaris. That's simple, guys. It's it's a simple, you've been doing it in all your BDS, your Viva questions. Radix entomolaris is a supernumerary distal lingual root in a mandibular molar. Radix paramolaris is present mesiobuccally to the mesial root, so the direction is mesiobuccal. Okay, some controversy is there whether this mesiobuccal option was there or not, guys. Yes, it was there. Just a sec, I think my system has hung. Just give me 2 seconds. Just a sec, guys. Unable to move my screen here. Yeah, I think we are going to come back here. Yeah, fine. Excellent. We are back. Thank God for that. Yeah, where are we? Yep. Yeah. So you have radix paramolaris. The answer is pretty simple, guys, here. The answer is the extra mesiobuccal root, right? Very simple, very basic. Then you have another IBQ again, a very, very, basic level, like even I think a second year, third year undergraduate would answer that. You had this apical section of the root that they showed, right? And you have the main canal, and you had all these, apical ramifications that they had shown. All these apical ramifications, right? Very basic question. And the options were so funny, right? Alpha, beta, gamma, delta. So it's a delta, right? It's like a tributary. It's like, the river Ganges flowing finally into the Bay of Bengal with a delta in the Sundarbans. That's where the term comes from. So the answer is pretty simple here. Very commonsensical question. Um, you don't even require a reference for this. It's a delta, isn't it? Fine, right, guys? That's a delta. Okay, now this is a good one. There are certain principles that are supposed to be followed for periapical surgery, guys. Okay, now which of the following is not one of those standard principles? So the first option, mandibular incisor, a vestibular incision is good. Yes, that's right. Because when you're trying to approach a mandibular incisor for a periapical surgery, a vestibular incision is many times preferred, although it's tricky. You have to kind of sometimes dissect the platysma muscle and you can have some complications, but people do that. A horizontal incision in the gingival sulcus in a periodontally compromised tooth is the norm. Yes, that's also true. You know why? Because basically what he's saying is that what about a submarginal or an Austenbein loop K incision? You don't do that in a periodontally compromised tooth. You do that in a tooth which has got crowns, right? When you already have less attached gingiva, why do you want to take a chance with a submarginal or a semilunar or a Austenbein loop K incision? So in a periodontally compromised tooth, you better, you know, go into the gingival sulcus and give a horizontal incision following the contours of the gingiva. Then third option is also seems to be right. Interproximal gingiva is preserved. It acts as the anchor tissue for the suture placement. So you have to be very careful with the interproximal gingiva. You have to raise it fully, do not traumatize it, or you can make a papilla-based flap wherein you're just cutting a horizontal incision right at the base of the triangle of the interproximal gingiva so that you don't even you don't disturb it, and when you suture it back, when you suture the rest of the flap back, you don't disturb the interdental papilla, right? So that's also there. The fourth option was vertical incisions when indicated are placed at obtuse angles to horizontal incisions. Now this is an old concept, guys. Earlier they used to do that. Okay, earlier what used to happen was that's your tooth, yes, that's your root, that's your tooth, that's your root. So if you're giving a vertical incision, earlier used to do like this, right? Make it at an obtuse angle, because they used to say that the base of the flap should retain its vascularity. so that it does not undergo necrosis. Nowadays, that's not a great idea. If you see the latest, or not just the latest, this actually has been in practice since 15 years now, more than 15 years, that now you should give at exactly right angle. If you have to give a vertical incision, give exactly at right angle to the horizontal incision, because this way you will be severing or cutting less minor blood vessels. So your blood vessels, your hemorrhage would be less. Your healing post surgery would be less eventful. Right? So that's the answer, guys. This is not a standard practice that you do. You can do it in some situations, but this is not a standard principle that you're supposed to follow. The standard principle is vertical incision has to be exactly perpendicular to the horizontal incision. Yes, so that's the answer. Next question. During caries excavation of a 7-year-old child in a permanent molar. Now, permanent molar was mentioned. Now, this is extremely tricky question. I'll tell you why. Two reasons. Pulp is exposed. You have decided, the examiner tells you don't have to apply your head here. The examiner tells you want to do a pulpotomy. The examiner is asking us, what is the material of choice here? What is the material of choice? Okay. Now, guys, in all our VPT lectures, we've been telling you, the best is calcium silicate based cement like MTA, biodentine, etc. Whether it's for a pulpotomy, whether it's a partial pulpotomy or a full pulpotomy, whether it's a deciduous tooth or a permanent tooth. Okay. Right? But what if calcium silicate based cement is not in the options? If you see the options, you have zinc oxide eugenol, you have calcium hydroxide, you have pharmacology, and you have GIC. You do not have a calcium silicate based cement in the option. Then what do you do? Then, guys, for a primary tooth, pharmacology is better than calcium hydroxide. But for a permanent tooth, calcium hydroxide is better than pharmacology. Therefore, when it's mentioned permanent molar, it's a 7-year-old child, so in all likelihood, it's the first permanent molar, then calcium hydroxide is the answer, guys. Yes? So pretty tricky question in the sense that the options did not help us. We had to apply our heads. We had to have the knowledge. So yeah, that's there. Next question, guys. Cutting efficiency of high-speed handpiece. Wow. Efficiency versus effectiveness. We always cover this. You see our notes, timestamped notes. So you have efficiency, you have effectiveness when you cut the tooth structure. Efficiency is the amount of heat that is generated, not just the amount of tooth that is being cut. Effectiveness is simple. I mean, you can just generate too much friction, but if you're cutting the tooth in less time, it's great. But efficiency also takes care of the fact that you're not generating too much heat. So if you're using a dull burr, you will generate very high amount of heat. So use a sharp burr and high speeds. So using a sharp burr increases the efficiency and high speed increases both efficiency and effectiveness. So the best answer here is sharpness of the burr and rotational speed. Yes, it's a good applied question. As always, we have dealt with this even in our notes. I mean, obviously, all these things we've been telling you in our GTs and our live lectures and recordings, etc., etc. But there are things which are just absolutely there in front of you as part of the notes. Yes. Guys, this is simple. One of the simplest questions. The next question, non-vital tooth, the examiner tells you. It's an open apex tooth. There was an X-ray, a clear-cut X-ray was showing, the upper central incisors, both open apex, right? And non-vital open apex teeth, they are permanent teeth, permanent central incisors. It is decided to obturate after barrier formation. So the examiner is telling us this is non-vital. The examiner is telling us, I want to make a barrier and then only I want to obturate, okay? I want to make a barrier and then only I want to obturate. It's simple, right, guys? You cannot have a vital pulp therapy as the option. You cannot have a revascularization as the answer, isn't it? You have to have a conventional root canal treatment, but it's an open apex case, so you need a barrier. So you do apexification, isn't it? So answer is apexification. Very simple. So many times discussed, as I just shared the screenshots of our traumatology notes also. Which of the following has effect on pulpal health? Maximum effect on pulpal health. The most important. See, everything is important. If you see the structure and functions of the dentine pulp complex and the pulpal responses to the dentistogenic assaults or the pulpal responses to iatrogenic exposures. You see heat is important. You see so many other factors. The pressure that you're applying is important. The use of coolant is important. But the most important is, as I always mention, is to spend so much time whenever I'm doing operative dentistry. As you can see here in the screenshots also, so much time I spend on RDT. RDT is the single most important thing which decides how much of pulpal injury will be there when you're doing your procedures, right, in operative dentistry. So the answer here is RDT. Yes, everything else is also important, polymerization, shrinkage, that would cause micro leakage and so on and so forth. You have heat generation, very important, coolant, very important, but RDT is the single most important, right? And if you see my notes, our notes at DBMCI, you see everywhere RDT, 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 so many times we mentioned. Referred pain is carried by, wow, I'm so happy that I always spend so much time when I'm doing endodontic diagnosis. I always spend so much time discussing the pain pathway with you, discussing the various types of A, B, and C fibers that are there in the dentine pulp complex, and telling you all the potential important MCQs from there. So referred pain is carried by C fibers, guys. That's the answer. Simple. Well, the examiner was pretty smart. The other three options are also actually, A delta, A beta, A gamma. They're all present in the dentine pulp complex and the PDL, isn't it? And C fibers. He did not give you A alpha, isn't it? He did not give you B fibers. But the answer for referred pain is C fibers. The answer for central sensitization is also C fibers. Anything that is too bad with the tooth, isn't it? It's all carried by C fibers. A delta is like momentary pain of dentinal hypersensitivity or superficial caries, isn't it? Okay, next question, guys. So, as always, dealt with in great detail in our lectures, in our notes, which are there with you always. Soft copy, hard copy, everything. Okay, guys. Next question. To achieve profound anesthesia in a mandibular molar with irreversible pulpitis, what anesthesia should you give? So, he's basically asking you the management of a hot tooth, right? So, you should give out of all these options. I mean, commonsensical, topical, nothing works in mandible. Topical doesn't work. Infiltration can work, but with articaine, yes, and that too limited. Inferior alveolar nerve block you have to give, but in a hot tooth, better to give a supplementary intraligamentary injection. So that's the answer, guys. Pretty simple. Yes. Okay, a soft fluctuant swelling is present in relation to a necrotic mandibular molar. Along with endodontic treatment or pulpectomy, I think pulpectomy was probably there in the question. Pulpectomy is not the ideal word, isn't it, for necrotic tooth? You actually debride the necrotic tooth. You don't have a viable pulp, right? But anyways, what should be done? So along with the root canal treatment or an endodontic treatment or pulpectomy, which is not very accurate, what else should you do? I mean, the answer is obvious. It's a soft and fluctuant swelling. Go ahead and do an IND to prevent further space infection, right? So out of the options, IPC doesn't make sense because the tooth is non-vital. Anti-sensitivity paste doesn't make sense because the tooth is non-vital. Pulp testing after 7 to 10 days doesn't make sense because the tooth is necrotic. So obviously the answer is incision and drainage. Answer is incision and drainage. Can I just look at the chat also? Remaining dentine thickness, dear. RDT is remaining dentin thickness, vitality maintained. I marked formocrysol. No, dear. Formocrysol, Namrata, is a good answer for a deciduous tooth pulpotomy. RDT is remaining dentine thickness. Cannot know why you're doing, sir. Cannot know what you are doing, sir. Okay, you cannot understand. Ask, sir. According to IDT, it is formocrysol. No, dear. Calcium hydroxide. I don't know. It was permanent tooth. Beta permanent tooth tha. Okay, if it was a primary tooth there, then formocrysol is the right answer. If it is a permanent tooth, sympathetic fibers is also not the option. RDT beta is remaining dentine thickness. Have I solved all these doubts? Reimplant, 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 cementum, cementum. Is that fine? Oh. Beta happy is if it was deciduous, then yes, then formocrysol is the right answer. If it was permanent, then calcium hydroxide is the right answer. There's no doubt about it. Okay. So, anyways, okay, this was simple. ठीक है beta. Okay, Anirban. If it is primary, then formocrysol is the answer. Then no doubt. Okay. Then there is no doubt. Okay. Following. Hot try. Thank you, sir. Shalini, thank you. Surfer incisor, they give permanent. Serapi is right. ठीक है बेटा, don't worry about this. Whatever was you gave the exam, that's okay. You know both the answers, so that's right. Okay, guys. So following a traumatic injury to the tooth, IOPS shows roots. This is the simplest answer. IOPS shows root surface with jagged margins, with cupped out, radiolucent areas. External root resorption is the answer. So many times we've done this. During chemomechanical preparation of the root canal, danger zone is referred to. It is the inner curvature, guys, where the dentine is thin. Inner curvature of the curved part of the root canal. Now that corresponds many a times to the furcation area of the distal surface of the mesial root. Yes, but the danger zone, yes, furcation area can be a danger zone for the distal aspect of the mesial root, but the more better answer, because in generalized, it's not just that danger zone is only there in the distal half of in the distal part of the mesial root. You can have a danger area in anywhere where dentine is thin, and that is most commonly with the inner side of the curvature of the root canal. So inner curvature of a curved canal is the answer, guys. Okay, is the answer, guys. हाँ वो तो होता ही है डियर इंट्रालिगामेंट्री ब्लॉक फॉर हीमोफिलिया होता है बट आई मीन यू कैन ऑलवेज गिव इट टू any case which is not which you think is tough to anesthetize, right? Placement of calcium hydroxide, this is very simple, guys. Lentulospiral. Placement of calcium hydroxide in canal is done by lentulospiral. This is very simple. Or correct order of fish, beta ICIS, right? Zone of infection, contamination. This is very simple. You've been doing this since your third year BDS. So zone of infection, contamination, irritation, and stimulation. Okay. So infection, contamination, irritation, and stimulation. Beta furcation abhi bataya na Sakshi that furcation is one of the danger areas, but the better answer is the inner curvature of a curved canal, because you can have a danger area in a maxillary first premolar buccal root where the palatal, where it is curving palatally and the inner curvature has thin dentines. That's also a danger zone. You can have a danger zone in a danger area in a C-shaped canal where the inner curvature is very thin. You understand? So the better answer would be this thing. So zone of infection, contamination, irritation, and stimulation is the answer, guys. Which of the following is a natural scaffold? Now, guys, this is a new one, tough one. You will have to memorize this. Hyaluronic acid is the answer because this is polylactic, polyglycolic, and polylactic co-glycolic. They're all artificial. Hyaluronic acid is a natural scaffold. Right, guys? So where was mentioned hot tooth? Beta nahi hot tooth, any mandibular molar, not which is irreversible pulpitis, is considered. When you do give anesthesia, you consider you have to do your best, right? So you have to give. Okay, guys. So question में sharp pain mention किया था तो no dear, I don't think so. I don't think so. Anyways, fine, guys. So endo is done. Let's look at the DM part. Yes. Yes, guys, are you all with me? हाँ हाँ, profound anesthesia हो सकता है बेटा, but come on, mandibular molar irreversible pulpitis, if you have an option with a supplementary technique like intraligamentary or osseous, intraosseous, go with that. Okay, that is a better answer. INB, obviously we do give INB and we hope that it works, but if you have in the question another option with a supplementary technique, go with that. Okay, right, guys, referred pain C fibers है बेटा. Okay. Anyways, okay, guys. So next question, DM. Which component minimizes polymerization shrinkage? So many times I've told you guys, anything good with your composite, whether it's reducing polymerization shrinkage, reducing water sorption, improving physical and mechanical properties, it's your inorganic filler. Okay. So the answer is inorganic filler. Yes, ठीक है बेटा. Okay, good. So that's from our notes. You have everything that is there with your fillers. They improve the physical properties of composites. What is true regarding soldering of austenitic stainless steel? Now, this was a tough one, guys. I want everybody's attention here. So basically, what is happening here is you have soldering of austenitic stainless steel. Okay, soldering of austenitic stainless steel. So you have austenite which is stainless steel, which is basically iron. You have carbon. You have chromium to give it passivity, right? 12 to 30%, right? Now, what happens is when you're trying to solder it, you're raising it to a high temperature of about 400 to 900 degrees Celsius. The problem is at these high temperatures, you are sometimes losing your chromium in the form of carbides. So chromium carbide is lost, right? Is lost, and this predisposes to what is known as intergranular corrosion. Okay, not intra, but intergranular corrosion. Right now, I'll tell you how the examiners were confusing us. This is a brand new question taken from in between the lines. I do not expect anybody to answer this correctly. Please, if you did not have an idea, you should have left this question. This is one of those 2-3 questions which you should. Guys, I hope you know 240 out of 240, you're not supposed to mark, okay? Yes. So this is one of those questions. So guys, here, if you see, at high temperatures, tantalum carbide is formed. Partially right. It does form, and it helps in protecting the chromium. Instead of chromium carbide, tantalum carbide is formed. But the second part of the option is wrong, right? Which depletes chromium. So that's why this is wrong. At high temperatures, titanium oxide is formed. This is wrong because titanium, just like tantalum, is sometimes added to again form. It acts as a sacrificial kind of a component, which itself forms carbides instead of chromium carbide, so as to retain the chromium there, so that your stainless steel remains stainless, does not undergo corrosion. The third option is between 400 to 900 degrees Celsius, chromium is depleted. That leads to intergranular corrosion. Now, this is right. C is the answer. What is D option, guys? Between 400 and 900 degrees Celsius, chromium carbide is formed. You are right till here. Is formed that leads to intragranular. This is wrong. So that's why D option is the wrong answer. So guys, very good, excellent. Intergranular, theek hai. Happy you're right. Wow, wonderful. Excellent. Between 400 to 900 degrees Celsius, chromium is depleted. That leads to intergranular corrosion. C is the answer. Congratulations, happy. True about glaze. Again, tough one, very tough one. Again, I do not. These are the 2 questions in DM. I do not expect you to answer. If you've got these right, excellent. You are, congratulations. So, guys, what about glaze? Glaze, we all know it's that surface shiny layer which is, fired on a porcelain so that it gives you nice, gloss to the surface, right? Now, there are certain points about glaze. Self glaze. So, what are the important points? The important points are that when you do a glaze, you basically prefer a material which shows low expansion at when you fire it at high temperature. Okay, that is one. Okay, and the other important thing is that while it is cooling, the underlying ceramic, right, portion, or the core of the ceramic, or the underlying ceramic underneath the glaze layer, it undergoes more contraction, which pulls the outer glaze layer towards itself. So it remains in a state of residual contraction, not expansion, contraction, which prevents crack propagation. Okay. The other important thing is, which Phillips does not mention, only Craig mentions. So as I said, this is one of those outliers you are not supposed to answer if you don't know. So self-glaze, there's an important point, does not improve. Self-glaze does not improve. Self-glaze does not improve the flexural strength. Okay, so that is also a fact with glaze. You just have to memorize this. Okay, does not improve flexural strength. Does not improve. Okay, so first option, self-glaze does not improve flexural strength. First part seems right. But the second part is high expansion at low temperature. This is wrong. So this cannot be the answer. Why? Because glaze always has low expansion at high temperature. Next option, glaze layer is under a compressive stress, contraction. Okay. Due to more contraction of coarse ceramic that helps in prevention of crack propagation. That is the answer, guys. Now, if you've got this answer right, those of you who've got this answer right, pat your back. Right? That is the answer. Third option, glaze layer is under tensile stress due to expansion of coarse ceramic. That's absolutely wrong. Fourth option, self-glaze improves the flexural strength. That's wrong. it does not have much effect on the flexural strength. So this was a question which was, Beta Sonia, irreversible pulpitis mentioned, not hot tooth. In general, by default, hot tooth is a mandibular molar or a premolar with irreversible pulpitis. Many a times, many authors, even Dr. Malamed, considers them to be a hot tooth, and you have to go with that philosophy when you're approaching the patient. Okay, it's always better. I mean, we don't do it because we don't have the armamentarium. You don't have 30 gauge needles, you don't have intraligamentary needles, so we don't do that when we are in college, but you should. Okay, so I hope that's clear. Wow, Ria, excellent. Wow, 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 excellent. Leafort. Wow, man. Wow. You marked it right, Sakshi, Sanjay, Ajay. Wow, man. That's wonderful. Excellent. 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 Okay, for phosphate bonded investment material after setting reaction and burnout, resultant chemical product. Straight from our notes, guys. This is the screenshot straight from the notes that you all have. I mean, those our students have, our friends have. So you can see here, lastly, you have Mg3P2O4 whole twice. Okay. Mg3P2O4 whole twice. That's the answer. कोई बात नहीं बेटा. So you had this was a tough one, guys. I mean, in my time, I would never remember this entire reaction. So although I've put that in your notes, and those of you who could, get it right, wonderful. But yeah, this was a tough one. So you had the options of ammonium, hydrogen phosphate, colloidal, multimolecular ammonium, magnesium phosphate, .6H2O. You have magnesium pyrophosphate crystalline, Mg2P2O7. That's actually the second last product. So many people would get this answer and would get this wrong. But the answer is Mg3P2O4 all twice. Okay. This is actually unfortunate. I mean, okay, fine. We had this in our notes. Our students had the advantage, but I mean, what's the logic? I mean, you're just cramming up so much data, but can't help it, guys. Okay, this is simple, guys. So many times I always keep telling you straight from the notes. If you add a chemical modifier, accelerator and retarder, you're always going to compromise the intercrystalline cohesion of your gypsum, and you're going to decrease the strength, whether it's wet strength or dry strength, right? So you're going to both reduce both the wet strength and the dry strength. You see it clearly mentioned in the notes. Strength decreases when you add these chemical modifiers. Straight bang on from our lectures and our notes. कौन सा छोड़ा बेटा? हाँ ठीक है, अच्छा है. If you've left that question of Mg3P2O4 whole twice, good. You have to be very intelligent to leave those 12 to 15 questions in a 240 question paper. You really stand a good chance of getting a good rank when you intelligently leave some questions. In fact, 3 days before, when I took your morning motivation, 4 days before, I told you don't do akkad bakkad bambe bo. If you should take your chances only if you've eliminated two options and you're confused between two, and you can make a calculated guess. That's the golden rule. Okay, so this is done, guys. Accelerators and retarders are added to gypsum. What is their effect? Reduces both wet and dry strength. Hope everybody got that right, at least our students. I keep on telling this at different platforms, whether it's GT, live class, etc. A 30 fluted carbide burr, guys. 30 fluted carbide burr is, for, again, many a times we keep telling this, which is true. So guys, actually, if you see the table, this is right from our notes also, in your textbook also. So you have 18 to 30 fluted burr. It's actually finishing, but you all know, common sense, finishing continues into polishing. So if you just keep on doing it for some more time, you eventually end up polishing it, right? And also, the other options did not make sense. Like, it is not a rough or elevated surface that you will get. You're not doing bulk reduction with a 30 fluted burr. So obviously the answer is a smooth polished surface. Smooth polished surface, that's the answer, isn't it? Yes, guys. So B, smooth polished surface. I hope all our students could get this right directly straight from our notes, lectures. Great question, guys. A material's viscosity decreases under pressure and increases back on rest. Now, I'll tell you what. Now, the examiner is very smart here. He's basically talking of the shear thinning phenomenon, in which you have pseudoplasticity and you have thixotropy. Now, guys, what is the one difference that is there? The one difference that is there is that pseudoplastic materials immediately on rest regain their viscosity, whereas thixotropy is a time-dependent behavior. It takes some time. Yes. Now, in the exam, a material's viscosity decreases under pressure and increases back on rest. Ideally, what they basically mean that it increases immediately back on rest. They should have added the word immediately. And the answer is pseudoplasticity, guys, not thixotropy here. Those of you who marked thixotropy, guys, the answer is pseudoplasticity. Okay. This is tough one. I think 70% of you will get this wrong, but that's okay. Pseudoplasticity is the answer. So don't worry, guys. You're not alone if you got this wrong. Pseudoplasticity is the answer. If they would have written that it took some time for it to get back, for the viscosity to get back to its original high value, then it's thixotropy. If it's immediately, or although immediately word was not there, but you could make out that this is what the examiner means. It increases back on rest. So that means pretty fast. So guys, pseudoplasticity answer. Oh, order of linear contraction, guys. So many times that's straight from our notes. You see here dimensional stability order or the order of linear contraction. So many times we've told you this is straight from the notes, guys. Yes. And also in our lectures, we keep making this graph. Yes. So the highest is for what? Condensation silicone, polysulfide, polyether, addition silicone, right? So the answer is, what is the answer, guys? Answer is A, condensation silicone highest, then polysulfide, polyether, addition silicone. ठीक है? ठीक है, dear. कोई बात नहीं बेटा, that's okay. This was a tricky one. Not this one, the previous. Thixo and pseudo. Don't worry. Okay, clinician wants, this is simple, guys. Clinician wants accurate impression, wants to pour multiple impressions, no reaction byproducts are formed, voids हैं, material is hydrophobic. So the answer is addition silicone. कोई बात नहीं बेटा. Addition silicone भी ठीक क्या होगा? Addition silicone. So that's again straight from the notes. You have the addition silicone, hydrogen is formed, may be released, leading to voids. Yes, no reaction byproducts are there. Yes, so addition silicone is the answer. Which of the following has biocompatibility issues due to potential toxicity, guys? Beryllium and nickel chromium alloy. That's simple. Yes, again straight from the notes. Beryllium highly toxic. Yes, beryllium highly toxic. Beryllium ठीक है ना बेटा? Okay. While mixing the powder and liquid for autopolymerizing cold cure, setting is taking place too fast. So basically, you have your inhibitor, that's your hydroquinone, which actually ensures that you have adequate working time in a cold cure. That is, if that is less, obviously setting will take place too fast with a lot of heat generation. So the answer is reduced inhibitor. Okay, simple. Reduced inhibitor. Beryllium, ठीक है. This is reduced inhibitor, guys. Mercury and gallium, they are liquid at room temperature because of their low melting point, isn't it? Low melting point. Oxygen layer adsorbed. Now this is a tough one, guys. Oxygen layer that is adsorbed on the surface of gold. Now, oxygen layer that is adsorbed on the surface of gold and platinum is basically very weak bond. That's a secondary bond. That's a van der Waal. Okay. And the oxygen layer that is absorbed on silver is actually a covalent bond. It's a primary bond. So that is known as chemisorption. So when you're asked gold, the answer here is van der Waals. Okay, so that's a tough one. The answer is van der Waals. Again, very tough one, guys. We don't expect you to remember this, but that's okay. So even if you've left this, that's okay. So 2-3 questions, even if you leave in DM, that's fine. But those of you who marked van der Waals, great, congratulations. अरे यार कोई बात नहीं, कोई बात नहीं. ठीक है? Right, guys? So these are the papers, these are the papers which appear on the first thing. They appear simple, but they're not actually simple when you're in that high pressure cooker situation wherein you're supposed to. And, obviously, I'm not here to analyze the entire paper, but I've heard that, your medicine, surgery, all were tough. So, yeah, things are, yeah, so pretty intense, guys. I hope all of us do well. And yeah, the paper is tough. I agree. I agree. The paper is tough. On the first look, these papers appear easy, but it was tough, guys. Yes. No, dear, it's tough for everyone. So the very intelligent, as we, in patients, you do case selection, similarly question selection. You have to know those 10 to 15 questions that you have to leave very intelligently. But no worries, dear. Easiest exam ever. That's good, guys. So thermal expansion. Beta thermal expansion नहीं. उसका आंसर remaining dentine thickness था. The most important, this thing for thermal injury. Anyways, guys. Yeah. Yeah, but best of luck, guys. And I think next up is your surgery recall with Dr. Pawan Kandari. And I'll see you around. Good, guys. Take care. Stay connected. Best of luck. Best of luck to everybody. Leaving 20 questions is a good thing. 15 to 20 questions is not bad. Chalo, good. Best of luck, guys. Best of luck for the result and stay connected. Thanks, guys. Bye.
Okay, okay. So hi, afternoon friends, afternoon everybody, bache, afternoon everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS PharMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. So let's start. Let's start with our path and micro discussion. Now, before I even go further, I know that the paper was extremely lengthy, and as Sonia has beautifully put it, it was all about time management and leaving options selectively and stuff. Firstly. Secondly, I am not able to comprehend at all. Key post-COVID, why are the number of medical questions increasing so much? That is out of 240 total questions, you are getting about 100 plus medical questions. That is crazy. So, but as in this year of preparation, especially for the juniors, this session is more helpful for the juniors. Firstly, because you get to know the hang of the topic, that this is what is asked, this is what we have to prepare. And for the exam going students, that is for the students who gave the exam, you get a broad idea where we start. As usual, life में tension नहीं लेनी है. Any question that you think, I know Sumi, a paper was difficult. मतलब वो, it is easy for a third person to say it was a moderate to difficult paper, but the students who are actually sitting in the paper, giving so many medical questions and all, it's not a easy paper at all. Now let us start with path and micro. I agree, dear. I agree. Starting with our first question. Acha, one thing that I realized was so many students told me कि sir, we were able to recall the topics. Ki all these topics were covered. It was like an MBBS paper. Tanya, I agreed. Matlab, the level of questions that were asked in the medical subjects was as good as MBBS level. So let's start. Let's start. So for the juniors, a very important carry home message: weightage of dental subjects is equal to the weightage of medical subjects. We are here to beat the system. I am not here to increase your knowledge. सारी knowledge हम MDS में आके increase करेंगे. I'm here to make sure that we get through. So, yes, I agree. If we have to choose the best possible dental doctors and award them a MDS degree, it should be on the basis of dental यार. Medical के पूछ लो ना 30-40 question, 100 थोड़ी. So starting with the first question, बच्चे, ADA deficiency है, adenosine deaminase deficiency. You very well know that the diagnosis is SCID, severe combined immunodeficiency. The paper was lengthy. It was few of my closest friends are dental students, and they were telling me that they marked few questions marked for review and they were not able to go back to those and see it. नहीं, रिग्रेट नहीं करना है, बिल्कुल रिग्रेट नहीं करना. नहीं बच्चे, GNN187, it wasn't neutrophil, severe combined immunodeficiency. ADA deficiency is associated with SCID. हम लोगों ने याद है, we had studied this under the combined B and T cell defects. T cell defect was Dijk's syndrome. Combined B and T cell defect was SCID, which occurs due to ADA deficiency. I have put the screenshots of notes and all दोबारा से. So because it is a combined B and T cell defect, the clinically it was more commonly associated with infections by milder organisms. And which is, yes, I agree it is combined, but which is the main defect? It is a defect in T cells, which in turn is followed by defect in B cells. The answer to be marked was T lymphocytes. Dela, it happens. Life may papers are unpredictable. That is why you cannot afford to leave any subject. Path, Acha, I'll tell you one more thing. Just 2 minutes. Path, micro combined. Usually we get 15 questions, whether it is NEET, INI. Previous 2 years, we were getting more questions from micro. We used to have 11, 12 questions from micro, 4, 5 from path. This was the breakup previous 2 years. This time in NEET PG, we had 11, 12 questions from path. It was full of anemias, images, and all. And we just had 3, 4 questions from micro. So the trend reversed. Physio, biochemistry, 14 questions each. Pharma, close to 20 questions. Medicine तो crazy था यार. I know review नहीं कर पाए. I know. In dental section also medicine questions were there. Medicine was crazy. अच्छा ये देखो. Have a look at this. Chronic alcoholic. Alcoholic है with hepatomegaly. Alcohol is associated with fatty liver disease ना. All of us know this. It is associated with fatty liver disease. उसके बाद fat droplets भी history में दिया हुआ था. All this white is fat. So which is the stain used for fat? Oil redo. We always stress, even I and I, you have had 1, 2 questions on stains. Fat, oil red of fresh fat, oil red of fixed Sudan black. Asha, there was another stain question. Pharma was all over. Iron का stain पूछा गया था, Prussian blue. I have put that question. So stains, calcium most common one cosa, specific alizarin redness. मैं फटाफट से 1, 2 points और कह रहा हूँ because that can be helpful in INI also. So please have a good look at the stains. Fat, that question was straightforward. Oil redo. Oil redo. Next, after extraction, a 7-year boy, 7-year boy, matlab he is a male, he is having uncontrolled bleeding. Maternal uncle has same problem. So males are affected, na? Uh, नहीं विशाली अच्छा नाउ दैट तुमने ना इतना सीरियस उस टोन में बोला कि ग्रो अप डॉक्टर्स एंड ऑल नहीं दोस्त नहीं विशाली लाइफ डजंट वर्क लाइक दैट आई एम बीइंग ब्लंट आई एम सेइंग सो बिकॉज एज एन एमबीबीएस डॉक्टर कोई मुझसे डेंटल का कुछ पूछे आई डोंट नो एनीथिंग अबाउट इट when I say I don't know anything about it, I'm telling you that 99.99% MBBS doctors don't know anything about the dental segment. We say a simple line that dentists will take care of it. So why can't dentists say the same? So अब उस चीज का कुछ नहीं हो सकता. The pattern of paper has to be changed. But fair enough. Next, now it is male predominant now. Males and maternal uncles. So it is a male predominant disorder. Male predominant XLR. X-linked recessive. Male predominant XLR. Remember हम लोगों ने when we were having a look at the class, we had seen that the male is diseased and mother's real brother, maternal uncle XLR. Mama Bhanja diseased, X-linked recessive. It was X-linked recessive. Uncle and nephew are diseased. Son was diseased because of maternal grandfather. Tanya, autosomal recessive nahi tha bache. It was XLR. It was XLR, X-linked recessive. XLR. Mama Bhanja diseased. Perfect, Ria. Perfect. Next question. Female patient presenting with fatigue, delayed healing of scratches, and multiple purple spots over her legs. The minute I know Mama Bhanja, to it does not skip generation, na Simran? वो son and mother's real brother बचे. X, that is classical X-linked recessive. It was not autosomal recessive. एक बार हम लोग notes को दोबारा देखेंगे ना, it is not, we had discussed this in detail while doing the pedigree chart analysis कि वो autosomal recessive क्यों नहीं था. It was XLR. Next question. Next question. बच्चे scurvy. Scurvy. When we talk of delayed wound healing, it is along with spots and all, it is scurvy. It is scurvy. Asha, it was one of the first questions. Next question. Next question. Acha, tell me this. Patient with history of GI infection was given prolonged broad spectrum antibiotic therapy. Clindamycin was mentioned, and now the patient is presenting with diarrhea. So after giving prolonged long spectrum antibiotics, now complaining of diarrhea. It is a case of Clostridium difficile infection. It is a case of CDAD. CDAD, Clostridium difficile associated diarrhea. We had seen why is it called difficile? Because it is difficult to isolate and grow. We had already seen that Clostridium difficile is a normal commensal of the gut. When broad spectrum antibiotics are given, when we use broad spectrum antibiotics, it kills the normal flora, that is, it kills the E. coli. So Clostridium difficile, it binds to the gut mucosa leading to diarrhea. That is CDAD. That is CDAD. नेक्स्ट, ठीक है ना? मतलब ये वाले एनीमिया वाले क्वेश्चंस थोड़े से देखते हैं. Patient with fatigue and pallor, blood investigation shows microcytic hypochromic anemia. The minute we talk of microcytic, नहीं बचे, नहीं नहीं उसमें ना वो delayed wound healing with spots ना classical survey होता है, classical survey होता है. Next, microcytic hypochromic anemia जब दिया है, when हाँ we discussed this in today's class only. Agreed. I know वो ना, if you have done the notes part well, as we are able to see, revised the notes and then you have to apply that knowledge in clinical based setup, then थोड़ा सा pseudomembranous, कोई बात नहीं, कोई बात नहीं. अब इसमें देखो, microcytic hypochromic anemia, the classical is iron deficiency anemia. But the examiner told you the second point, that it is associated with increased reticulocyte count. बच्चे, retic count, we had made the table of retic count low versus high. All nutritional anemias have a low retic count. Iron deficiency anemia, folic acid, B12 deficiency, they have a low retic count. Versus hemolytic anemias, which is the first thing that should come to your mind when we talk of a high retic count, that is hemolytic anemias. So microcytic hypochromic anemia, I agree that the most common cause is iron deficiency anemia. I agree. But if the examiner is saying in this question that it is associated with increased retic count and peripheral smear as hemolysis, it is a case of G6PD deficiency. It is G6PD deficiency. Please have a good look at this question. Iron deficiency anemia, megaloblastic anemia, that is nutritional deficiencies, and aplastic anemia. These three have a low retic count. They have a low retic count versus G6PD deficiency. It's a hemolytic anemia with high retic count, as you can clearly see in the retic count table. I know वो दोनों point, some students thought microcytic hypochromic, let me close my eyes and mark it as IDA, which was the first option also. I know, but वो main point था. There was another question, बच्चे, Kirtan, there were so many clinical based questions. अच्छा, ऑप्शन वाज hemolytic anemia. ठीक है, फेयर इनफ. इसमें तन्या हैज टोल्ड, या यज्ञेश हैज टोल्ड कि G6PD डेफिशिएंसी नहीं, hemolytic anemia लिखा हुआ था. एक ही बात है, इट्स द सेम थिंग. इट्स द सेम थिंग whether it is G6PD deficiency or hemolytic anemias which have a high retic count. Agreed, agreed. Next question. अच्छा, ये बताओ, a person who is working with animal hides presents with painless black ulcer on the forearm associated with edema. Now, animal hides and painless black ulcer, this is the malignant ischar. I know, बच्चे, वो microcytic hypochromic देख के ना many students marked it as IDA, but increased retic count था. I know. Next point. नहीं, मेडिकल कॉर्नर. नम्रता, कोई बात नहीं, कोई बात नहीं. अभी यू फॉरगॉटन व्हाट यू हैव मार्क्ड इज ओके. रेटिक काउंट भी 8% लिखा था. रेटिक काउंट, यू आर टेलिंग मी 8% रेटिक काउंट. नॉर्मल रेटिक काउंट इज 0.5 to 2.5%. 8% is very high. Next. But it is not aplastic anemia. Aplastic anemia has a low retic count. What I am saying, please have faith. Have faith. Next point. अगर एनिमल हाइड्स का हिस्ट्री दिया है, so this is a case of anthrax na, that is hide porter's disease with malignant blackish ulcers, that is malignant eschar formation. Anthrax, hide porter's disease, this is a case of hide porter's disease because the porters, they are carrying animal skin on the back. So ऐसे पकड़ा हुआ ना, there is malignant pustules on the forearm and the back, which is associated with Bacillus anthrax, hide porter's disease. नेक्स्ट पॉइंट, ये एंथ्रैक्स के साथ अपने तीन थे ना बच्चे, क्यूटेनियस एंथ्रैक्स और हाइपोटस डिजीज, pulmonary anthrax or wool-sorters disease, and lastly is the intestinal type. Agreed, agreed. Next, अच्छा ये वाला क्वेश्चन बताओ. Tell me this. Next question. I'm going to the next one. Have a look at this. Now, amastigote forms were written. Intracellular amastigote forms. I'm not even reading the other question. Hepatosplenomegaly, fever, weight loss can be seen in malaria also. But the minute amastigote forms are written, we are talking with respect to leishmaniasis, LD bodies, Kala Azar. I had put 5 questions in the DBMCI Telegram channel one day before the paper. Out of those 5, 3 have been asked. One was a question on Kala Azar, one I think was on hemolytic anemias, and the third was iron deficiency. So this was a case of Kala Azar. It is a protozoal infection, Leishmania donovani, Kala Azar spread by phlebotomous sandfly. Next point, it shows the presence of amastigote forms of the parasite on bone marrow biopsy. That is, it has LD bodies. LD bodies. हाँ, कोई बात नहीं, सीरियसली, मतलब when we get a rank and all, हाँ, बिहार patient, बिहार was also written, agreed, इसमें बिहार was also written, but अब वो बिहार देख के बिहार में मलेरिया भी तो हो सकता है ना. See, we always have to be extremely focused. See, what is the main point in the question? Main point was the presence of amastigote forms. बिहार से क्या diagnosis बनेगा? कुछ भी हो सकता है. But you were right, इसमें बिहार was also there. Bihar was also there. Next point. Next point. Have a look at this question now. Young female, fever, fatigue, weakness, tingling sensation, सब ठीक है. Microcytic hypochromic anemia. अब मुझे ये बताओ, the minute you have a look at tingling, we start thinking of megaloblastic anemia, at least clinically. But examiner clearly told you that it is a case of microcytic hypochromic anemia in a young female. Most common cause being iron deficiency anemia. Iron deficiency. I agree, Kala Azar is endemic in Bihar, बच्चे 100% agreed. But अगर वो समझो बनाना शेप्ड गेमेटोसाइट दिया होता बिहार में तो काला अजार थोड़ी मार्क करते. You always have to pick out the main point, Vasudha. That is what I am trying to tell you. Yes, there will be 4 pointers which will be given in the question. Learn the art of marking MCQs. There will be 4 points given. Point 1 and 3 are non-specific. They are pointing you towards the right answer. But the diagnostic one which is there has to be marked and got this. हाँ आदिति, हम लोगों ने माइक्रोसिटिक, दिस वाज द थर्ड क्वेश्चन जो क्विज से हम लोगों का ठीक हुआ था. 5 questions. How examiner was having anemia. Bang on right. Either she has a daughter, or or he had anemia. So अब ये तो बोलने की भी जरूरत नहीं है. Microcytic hypochromic anemia, most sensitive indicator being serum ferritin. You know this. Actually, another question was, in microcytic hypochromic anemia, that is iron deficiency anemia, serum iron reduces, serum ferritin reduces, TIBC increases. Serum iron reduces, ferritin reduces, TIBC increases. This was another question on iron deficiency anemia. There were 2-3 questions. There were 2-3 questions on iron deficiency anemia. Next question. Next question. Crescent shaped RBC. Simply such form of RBCs, the crescent shaped RBCs were given. It was a case of sickle cell anemia. It was sickle cell anemia. Exact image, you are able to see the presence of crescent shaped and sickle shaped RBCs. Agreed, वो heavy menstrual bleeding and stuff. नहीं बच्चे, excessive, how can, I know aplastic anemia is your favorite diagnosis, but excessive menstrual bleeding does not point to aplastic anemia at all. It does not. It does not. Next question. Next question. Small size central pallor बढ़ा हुआ है. Iron deficiency anemia. Plain and simple. We have seen the images. Hypersegmented neutrophil है तो megaloblastic anemia. Central pallor is more than 1/3. Iron deficiency anemia. ये pseudomembrane formation and stuff, watery diarrhea after prolonged broad spectrum antibiotics. You know this, that this is Clostridium difficile infection. You know this. You know this. अच्छा, दो. But it will not be hemolytic, bache. No, no, because if you're talking of which case for iron deficiency? Female है ना? Female excessive bleeding, most common cause of anemia, iron deficiency anemia. It will not be hemolytic anemias. It will not be hemolytic. Next point. Next point. Have a look at this now. Uh, I do have to answer the in case the students have some doubt. Now, अच्छा ठीक है. Malignant hypertension, it is associated with classical onion skin appearance. BP is very high. So the muscle layer undergoes concentric hyperplasia, that is hyperplastic cartillitis, onion skin appearance. Onion skin appearance. Next, there was this question in which diagnostic shallow endoscopy was performed and Pseudomonas aeruginosa का suspected infection था and endoscopy करनी है. How will you disinfect or sterilize the endoscope? You will use a high level disinfection. We use 2% Sidex. You will use 2% Sidex. नहीं ना नम्रता, ये तो अपना देख सीधा साधा था ना. ये from the notes itself, various modalities. What is the modality of choice for bronchoscope and cystoscope? 2% glutaldehyde, and I think students only told me कि 2% glutaldehyde Sidex. अब अगर ब्रोंकोस्कोपी करनी है, so we will use, I agree, वो कहीं पे हॉवल जॉली भी लिखा था. I agree to that. But जो हम लोगों ने answers mark किए ना, please consider them as absolute final for these set of questions. 2% glutaldehyde, high level disinfection. High level disinfection. Next point. Next point. बच्चे, हाँ, अच्छा, have a look at this. Middle-aged patient, tingling sensation. अच्छा, मुझे ये वाला बताओ. मुझे ये वाला बताओ. Middle-aged patient with fatigue, glossitis, neurological complaints, and tingling sensation in the limbs. In this case, because of the presence of glossitis, neurological complaints, and tingling sensation, all this is taking you towards megaloblastic anemia. And megaloblastic anemia, antibody against intrinsic factor, pernicious anemia. That is megaloblastic anemia or pernicious anemia. Next, which is the stain used for iron? Prussian blue. हमने वो stains में पहले भी देखा था ना. 2-3 stain questions were there. Fat, alredo, iron, Prussian blue. उसमें अभी suspected hemochromatosis है कि नहीं है, does not matter. Iron within hepatocytes was seen. Iron deposition, Prussian blue staining. You know the stains. We have done the stains. मतलब straightforward questions. Then there was a dentist who treated a patient with oral ulcer. Later developed vesicular lesion. ऐसा vesicular lesion आ गया. Histopathological examination shows the presence of Zang cells. The minute you see Zang cells, it is HSV1, it is herpes simplex 1. It is a case of HSV1. अब अगर वो आई एग्री, अब देखो कहीं पे अगर हॉवल जॉली लिखा हुआ है, इफ आई थिंक यू आर टॉकिंग अबाउट दिस केस, इट डज नॉट मैटर. ठीक है, आई एग्री कि इसमें चलो हॉवल जॉली लिखा है या नहीं लिखा, does not matter because all the other pointers, glossitis, tingling sensation, and neurological complaints point you towards megaloblastic. Yes, the paper was lengthy. Firstly, Tarun, you are right, it was lengthy. Secondly, when you are attempting or when you are listening to the recall session, it is not about this is the question, this is the answer, so go faster. I'm saying very frankly about this. You are not concerned with question answer at all. That is, no offense, but a stupid thought process because you need to know why the other options have been ruled out. Firstly. Secondly, question answer तो बच्चे वो PDF में वैसे ही मिल जाएंगे. The art of marking questions is important because INI में same topics repeat होते हैं. So this was viral. This was viral. अब यार मैं इससे फास्ट तो देखो मैं नहीं कर सकता, frankly speaking. अब अच्छा, सोनी सिंह, हॉवल जॉली मेगालोब्लास्टिक एंड पर्निशियस में था. अगर उस क्वेश्चन में इफ यू हैव दैट tingling sensation and glossitis and if megaloblastic anemia was in the options, then megaloblastic anemia will be a better answer. This will be the first answer, and then will be pernicious anemia, because pernicious anemia is a special subtype of megaloblastic anemia associated with antibody against intrinsic factor. In that case, megaloblastic anemia becomes a better answer. So it will depend upon the options given. Lastly, lastly, I guess this was the 17th or 18th question, क्योंकि we हमने बीच में से किया था. Most reliable test for diagnosis of primary stage of syphilis. Primary, where is the syphilis infection taking place? It enters the body at the site of infection, penis, vulva, cervix, vaginal canal, and all. Dark field microscopy. Dark field microscopy. So हाँ तरुण, परफेक्ट. VDRL नहीं बचे संजना. प्राइमरी स्टेज में ना VDRL is false negative. 30 to 40% cases are false negative. Primary stage of syphilis, it is completely full of the treponema are the lesion is full of treponema. हाँ, कुछ भी पूछते हैं अब. दिस इज अ फैक्ट. अच्छा, ये वाला हम लोग जब स्ट्रेप्टोकोकाई पढ़ रहे थे, कोला कलर्ड यूरिन, आई थिंक इट वाज अ हिस्ट्री ऑफ चाइल्ड विद कोला कलर्ड यूरिन, दैट इज इट इज एसोसिएटेड विद हेमाटूरिया. चाइल्ड विद हेमाटूरिया, कोला कलर्ड यूरिन, दिस इज नेफ्राइटिक सिंड्रोम, PSTN. स्ट्रेप्टोकोकाई वी हैड सीन. अच्छा, कंफर्मेटरी है तो ठीक है, वी माइट गो फॉर VDRL, बट अब इट विल डिपेंड अपॉन हाउ द क्वेश्चन इज आस्क्ड. मोस्ट रिलायबल टाइप पूछा है तो डार्क फील्ड माइक्रोस्कोपी, इट इज ब्रिमिंग विद. नहीं दोस्त नहीं, प्राइमरी स्टेज में TPHA ओवरऑल इज द मोस्ट स्पेसिफिक टेस्ट फॉर syphilis. If that is the question, answer is TPHA. प्राइमरी स्टेज क्लासिकली पूछा है, classical primary stage, we go for dark field microscopy. That lesion is full of syphilis. This is a case of PSTN nephritic syndrome. PSTN. Next, female patient, heavy menstrual bleeding, microcytic hypochromic RBCs, iron deficiency anemia. I guess ये हम पहले भी देख चुके हैं. अच्छा, एक ये तुम्हारा फेवरेट क्वेश्चन था, that child with low RBC count, bone marrow aspirate has decreased cellularity, fatty cell invasion. This is a case of aplastic anemia. This was aplastic anemia. नहीं बच्चे, IgA nephropathy is seen in adults. Child है ना तो PSG है. In that hematuria question, RBC cas और cola colored urine. Cola colored urine वाले question में child was given. Child is PSGN. अगर adult होता, then it would have been IgA nephropathy. Next point. So question was slightly different, but this the answer might vary. Answer might vary, but it will depending upon the language of the question, but classically this is what it is. So needless to say, whatever has been done has been done. Matlab, do not overthink about it. But if the same topics are asked in INI, they are repeated in INI, we will not be going wrong in that. आज ये बच्चे एडल्ट में है ना, MDS बिल्कुल भी नहीं होगा, MDS नहीं होगा. डन है दोस्तों, डन है. So on this note, we wrap up. Yes, Vanshika, but उसमें अगर if megaloblastic anemia is given in the options, first answer is megaloblastic anemia. If megaloblastic anemia is not in the option, then we mark pernicious anemia. बाकी तीनों तो बच्चे ऑप्शन में फिट हो ही नहीं रहे थे ना. Done. Done. So MDS नहीं बचे because anemia was there, pancytopenia. Classically, examiner is saying that it is associated with reduced bone marrow cell lati. कहाँ गया वो वाला question? This one. Bone marrow aspirate shows decreased cell lati with fatty cell invasion. All fatty cells invasion, all this is a feature of aplastic anemia. All this is aplastic, yeah. MDS is a hypercellular marrow. जब सब कुछ ही reduced है तो aplastic anemia होगा ना. Syphilis, अगर primary syphilis classically लिखा है ना, we go for dark field microscopy. Hemolytic नहीं बच्चे, when bleeding हो रही है, when bleeding is taking place in a young female, iron deficiency anemia, why will you think of hemolytic anemia in young female with bleeding? Not at all. 15 years to 65-year female, excessive bleeding, iron deficiency anemia. Done, done. So this takes care of the path and micro part. We had around 15, 16 questions combined, around 16 to 17 combined from this. And when you get a question, think straight from point A to point B. Don't go haywire, firstly. Secondly, extremely important, pick out the main point from the question and mark the answer. Do not try to fit in everything in medical questions because our medical knowledge is not this vast. Let's be frank about it. We have to know our shortcomings. And yes, paper was on the tougher side. So cut off अपना उसी हिसाब से कम जाएगा because in the end, all of you are competing with each other. So on this positive note, bache, good luck, and take care. Thank you. Thank you.
Okay, hi guys. Welcome to today's session. Just give me a minute. Okay, hi. Welcome to today's session. Today we are here to talk to you about the recall for the NEET MDS 2026, which we just had yesterday. And I'm here to discuss with you guys the surgery questions. I'm Dr. Pavan, and I'll be discussing with you the surgery questions. Okay, so yeah, let's quickly kind of cover these questions up. Okay, so this was the first question which was asked to you. Yeah. Okay, so this was the first question which was asked to you. Now, see, guys, what you need to understand is that whenever you guys have any particular question which was asked in any exam, all of you just go after and try to find answer to that particular question. But I can see that in this particular paper, there were at least 3 or 4 questions which were not the direct repeats, but they were from the topic which have been tested earlier. Okay, and this is a very good example of that. So I do remember that like you have one of the question which is based on the lymphangioma. Okay, and then I was taking one of the live sessions on the YouTube, and one student asked me that, you know what, how will you distinguish lymphangioma from hemangioma? And this is that particular exact question. So answer is definitely diascopy. So what you basically do is that you take a transparent film, you press on it. If at all it's a hemangioma, it is going to blanch. Hemangioma, it is going to blanch. But if at all it doesn't blanch, then it is basically lymphangioma. Okay, you understand my point? So this is how you kind of distinguish between hemangioma and the lymphangioma. Both appears like a bluish swelling on the tongue. Okay, so I hope you get that. Okay, right. I'll do it fast. I'll do it fast. Don't worry. Okay, so you can just go through it. This is how the kind of diascopy is kind of there. Yeah, this is how you can distinguish between the hemangioma and the lymphangioma. Now, this was the question which was asked to you. Now, the buzzword in this particular question, which I can feel is that it was a firm and it was mobile in the horizontal plane, but not in the vertical plane. Okay. Now, uh, can you tell me that what is the, like, was the image the same or the image was something different? Okay. Now, obviously, it's impossible to kind of replicate the exact image, but even if you leave the image out of the picture, if you just look at this, the firm swelling, which is mobile in the horizontal plane and not in the vertical plane, the answer comes out to be the nerve sheath tumor. Okay. Now, this is what is the characteristic thing over here. Now, there was a question which was asked to you earlier on the lipoma. Now, in my sessions, I have always talked to you about that this is basically a soft swelling. Okay. So I've always mentioned that, you know what, lipoma is basically a soft subcutaneous swelling, and it basically shows a characteristic slip sign. So in the exam, the examiner did not expected you that, you should know this nerve sheath tumor or something like that. What they actually wanted was that, are you able to, in your mind, rule out the other options? So why I would not say that the lipoma is an kind of answer, because it doesn't have this characteristic kind of movement in the horizontal plane and not in the vertical plane, and it is not a firm swelling. It is basically a soft swelling. Now coming to the hemangioma, okay, it's not an hemangioma because it is a subcutaneous swelling. Again, I teach this in my sessions. Traumatic neuroma, okay, and nerve sheath tumor. So the answer is the nerve sheath tumor. Traumatic neuroma basically occurs at the end and it is slightly painful. So that's a different story. Here, I would go ahead with the nerve sheath tumor. Now, it was completely a new question, but actually the examiner did not expected you that you should know about the nerve sheath tumor. What they expected is that, okay, have you developed the thought process over the previously asked question? Because the questions on the lipoma and the hemangioma have already been asked. Okay, so that's what they actually expected from you. Okay, now coming to the third question, this was a pretty straightforward question which you had. Yeah, like it was a pretty straightforward question. A patient was brought to the emergency after the fall from height, blah, blah, blah. BP is this much, pulse is this much. So basically hypertension with the bradycardia, the answer goes neurogenic shock. One of the simplest questions of all. So always you remember that, forget about it. Okay, history of fallen, blah, blah, blah. All those things are kind of different story altogether. But if at all you have any particular question where there is what you call as a hypotension with the bradycardia, the answer is neurogenic shock. Pretty straightforward question. Let me just answer whatever the guys you are kind of putting up. Just give me a minute. Uh, Live chat. Okay. Right. Different image. Obviously, it would have been a different image. Hematoma, tingling sensation, hematoma. Hematoma was an option, but again, hematoma will not have this characteristic movement in the horizontal plane and not able. See, because it is attached to the nerve. So you remember carotid body tumor? Carotid body is a tumor which is again a tumor of your kind of vessels. So it is movable in the horizontal plane, not movable in the vertical plane. So that was the concept which was being tested. If at all those buzzwords were there, that it is more able to move in the horizontal plane, not in the vertical plane. Okay. It was also mentioned, right? History, blah, blah, blah. Yeah, that's fine. Okay, perfect. Now, we are kind of caught up till here. Now, this is basically a direct screenshot from our kind of notes. So as you can see, neurogenic shock, bradycardia with hypertension. It is the only shock where you basically get the bradycardia with the hypertension. That is a neurogenic shock. Now, coming to this. A patient presented with lymphedema. Now, I have been shouting it for such a long period of time that, lymphatic system has become one of the important topics for you guys. And this is what is the stemmer sign. So that is what is a clinically a very, very important sign, which you basically use in order to diagnose it. So what you do is when you try to pinch the skin, you're not able to pinch the skin. That is what is a stemmer's sign. Okay, so this is again, we have covered this in detail in our notes as well, but this is what is the characteristic sign which was being tested to you. Okay, stemmer's sign. Okay, perfect. Now, what is this? Okay, so this is basically your gas gangrene. And whenever you have a patient with a gas gangrene, now in the exam, what I've heard from the students is that the image was even more gruesome and it has a lot of bullas and everything. So whenever you have this particular bulla development, it basically shows you that, it is already kind of gone to a level of a gas gangrene. So the gas has kind of started to produce. And whenever you have a patient with a gas gangrene, the only time when you really want to kind of save this particular leg is it is going to be a surgical debridement. Surgical debridement, fasciotomy, I don't know if it was there in the option or not, but that doesn't matter. What basically matters is this, surgical debridement. Surgical debridement along with antibiotic therapy. That is what you basically have to do. Okay. Okay. So I hope you able to understand this particular point, guys. Okay. Now, for fasciotomy is very, very specific for your compartment syndrome, and that is going to happen after trauma. Okay. So it's usually not that common after the insect bite, but that's not the point. The point is that only one option has the debridement, and that is what is the answer. Okay. Okay. Now coming to okay, so yeah, this is like I had recently conducted a live session in which I have kind of covered this in detail, and it's a very, very common thing. Like we keep on saying that whenever you have that particular crepitus or you have a development of a bulla, that basically tells you that you have developed a gas gangrene and immediate surgical debridement. That is what is the treatment for this particular stuff. Covered this in detail many times. Now, I want your help over here. So there's a 50-year-old, blah, 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 female in the neck, blah, 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 like swelling in the neck, noticed palpitations, and weight loss. And swelling moves with deglutination. So palpitation, weight loss, it basically is trying to tell you that, you know what, the patient is in the state of hyperthyroidism. Okay. Now help me with the options over here. Okay. Uh, Okay, help me with the options over here. Like, did you had a toxic multinodal goiter and the simple multinodal goiter both as an option or not? Even if you had both as an option, toxic multinodal goiter or any option which basically says a toxic goiter, that is what is the answer, because the patients have characteristic signs of hyperthyroidism, and that is possible only when you have this particular stuff. Okay, so I hope you understood this particular point. So hyperthyroidism. So whenever you have this particular kind of things of hyperthyroidism, like your weight loss and all those particular stuff, that basically it was a pretty simple question. It was just trying to tell you that, you know what, are you able to and appreciate that, you know what, this is what is a state of a hyperthyroidism. Okay, it doesn't matter. It is not an undifferentiated carcinoma. Simple goiter. Simple goiter. Simple goiter is not an answer. Okay, the simple goiter basically means that the signs of hyperthyroidism is not there. Simple goiter basically means that the thyroid gland is enlarged, but the thyroid hormones have not kind of increased. Okay, you understand my point? So in this, the any option which has toxic in it, toxic basically means hyperthyroidism. That was the answer over here. Okay, I hope you understood this point, right? Okay. Why not graves? In the graves, there is a uniform kind of an enlargement. So what I have heard from the students is that the image showed this bosselated appearance. In the graves, first of all, you will not have a very characteristic enlargement. It will be just be the antibodies which will be directed against that. So you will not have a very, very characteristic enlargement. Even if slight enlargement will be there, that will be homogeneous. It won't be this multinodular. And you will definitely not be able to see the like a thyroid in the Graves' disease, okay, with the deglutination and everything. Okay, so I hope you got this. Simple goiter is not the answer. Graves is not the answer. The answer over here is toxic multinodular goiter or a toxic goiter. Whatever was there in the option, that is what is the answer. Okay. Okay. Now, now another pattern which I noticed in this time's exam was that if they take up one particular topic, they've asked at least 2 or 3 questions over that. Now, why they are trying to do that? Just to see whether you have prepared that particular topic in detail, yes or no. You understand my point? Because one question you might get right by fluke, but like you cannot get every question right by fluke. Okay, you need that particular consistency in order to get all the questions right, and that is why they have asked multiple questions on the same topic. So this is something which you need to understand. And again, I'm repeating. There were many questions which were indirect repeats. It means that the question was not repeated, but that particular topic or that particular concept was repeated. So that is how you should ideally approach a PYQs. That is what you need to understand. Now this was a very, very dicey question. I tried to ask the students as well that, you know what, is there anything else which was given in the option or not or something like that? But here what they've given you is that they've given you that there is a patient with an increased BP, heart rate, blah, blah, blah. 4 into 4 centimeter swelling is given. Lymph nodes are palpable and moved with deglutination. Now this can be practically any thyroid swelling. Okay, any thyroid swelling, any thyroid malignancy can present like this. Okay, but they have not given anything. They have not given what you call any affinity finding or anything like that. But when it comes to this, you cannot start arguing in the exam. Like there's nobody to argue, right? So in your mind, what you need to understand is that papillary carcinothyroid, this is the most common thyroid malignancy. And the characteristic thing which they have given is lymph node spread. Now, lymph node spread can happen in all the malignancies, but early lymphatic metastasis is a characteristic feature of your papillary carcinothyroid. Diarrhea was there in the question. Okay, if diarrhea was there in the question, then it is a medullary carcinothyroid. But if at all the diarrhea was not in the question, then definitely the answer is papillary carcinothyroid. So somebody is kind of writing in the chat that, you know what, that what you call as the diarrhea was there in the options. If at all it was there, then yes, medullary will be the answer. But whatever I have talked about, like diarrhea was not mentioned. Okay, that's what I got to know. If diarrhea was mentioned, then medullary carcinothyroid, no doubt. Okay, if at all diarrhea is mentioned, no doubt it is a medullary carcinothyroid, no doubt. Okay, but I don't know. I don't know. You are the best judge. If at all the diarrhea was mentioned, then medullary carcinothyroid. If diarrhea was not mentioned, then it is a papillary carcinothyroid. Okay, so I hope you understand this particular point, guys. Okay. Okay. Okay, that makes a bit sense. That makes a bit sense. Somebody saying that features of pheochromocytoma were there. But see, like raised BP, okay, if at all it was a massively raised BP, and if at all specifically they have given you episodic, episodic hypertension. Okay, just a raised BP is not a feature of your pheochromocytoma. What you need is episodic hypertension. Okay, I hope you are able to understand this particular point. Okay, so I hope you got the drill. If at all the features of pheochromocytoma, episodic hypertension, blah 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 was given, diarrhea was given, then definitely it's a medullary calcium thyroid. But if at all they were not given, then I would go ahead with the papillary calcium thyroid. Okay, now I think at least 4-5 students are saying that diarrhea was there. If at all it was there, definitely it's a medullary calcium thyroid, no doubt about it. Okay, right. Now patient is operated for the elective hernia surgery. Now this I have taught like on the classes quite a lot, and always the students have a bit difficulty. I always used to think that, you know what, will they ask a question on this? But yes, they ultimately they ask that. Okay, so I hope you're able to understand this point. This is what is a clean surgery. Okay, so what they've given you that there is a routine hernia surgery. What is basically the kind of a thing? Okay, so what is the thing? It is a clean wound. Okay, so clean wound. I have covered this in detail in most of these particular my sessions. That, you know what, in the hernia surgery, you're not entering into the GIT. Okay, so you don't open the sac, you can kind of put a mesh over there. So what is it? It is basically a clean wound. And will you give a prophylactic antibiotic? No antibiotics needed. So now what you need to understand is that for the next time, probably they will not ask you whether it is a clean, contaminated, dirty. No. What they might ask you, they might ask you that, you know what, this is a surgery. Will you give a prophylactic antibiotic in the hernia? Prophylactic antibiotic is needed or not? The answer is no. Because what you need to understand is that if you give the antibiotic, if you don't give the antibiotic, the surgical site infection is the same. Okay, so I hope you got the understanding of this. Hernia is basically the clean. Okay, because they have given you that it was a routine hernia surgery. That's it. Now, a patient underwent a neck surgery 10 days after, blah, 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 surgery, there was a bleeding. Definitely, it is a secondary hemorrhage. Now, I have personally taught this at least 5 to 10 times in some or the other GT, in some or the other YouTube session or something like that. Any particular, secondary hemorrhage. So any particular hemorrhage after 21st, that is what is your secondary hemorrhage. Okay, so I hope you're able to understand this point. I personally have taught this at least 5 to 10 times. I'm pretty sure that all of you would have kind of done this particular question. Correct. And I'm talking about 5 to 10 times in the last 6 months. Okay, that's what I'm trying to say. Yeah, see, the point is that they did not, like, the recall which I have got is that, you know what, the decision of prescribing antibiotic therapy, the doctor wants to take that. But forget about the antibiotic. We are not saying that it is a clean wound because the antibiotic given, not given, or something like that. No, 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 no. What you need to understand is that elective hernia repair, no complications at all. It is a clean surgery. And for the clean surgery, if at all the doctor wants to decide whether antibiotic has to be given or not, the answer is no, it doesn't has to be given. Now, I don't know whether you found this particular question easy or what you call as difficult or something like that. But again, this is a very, 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 very characteristic example that, you know what, it is an indirect repeat. Okay, so from where is the repeat? I'll just tell you. Now, people like students have eaten my brain on the Telegram asking about this particular question. The least significant finding or blah, 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 palpable neck is what? Okay, now, very recently, I made a kind of document where I've shared this particular stuff. I told you that tenderness is wrong. Why tenderness is wrong? Because tenderness is kind of very diagnostic and significant finding, blah, 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 indicates rapid capsular stretching, which strongly points towards acute inflammation or infection etiology, acute lymphadenitis. You understand my point? Now, if you come to this particular question, coming to you with the caries tooth abscess along blah, blah, blah. So it's basically trying to tell you that there's some kind of an infection in the mouth and there is a tender mobile lymph node. After management with the antibiotics, the lymph node settles down. So everything is basically pointing towards an infection. What would have been the cause? Typical lymphadenitis, kind of a malignant metastatic lymph nodes, reactive lymphadenitis, or what you call as a lymphoma. It is a reactive lymphadenitis because typically lymphadenopathy, it basically forms a cold sore. Okay, it will not subside with the antibiotic. So here it is a reactive lymphadenitis because of an infection. Okay, so I hope you understand this particular point. Okay, so it is a reactive lymphadenitis. Okay, it is not a malignant metastatic lymph node. No, 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 no. Malignant diseases, it will not have a tender. It will have a what you call as a non-tender, and it will be fixed. Okay, if at all it is like malignant, then it is going to be fixed. It may be fixed or mobile, that's a different story altogether. But if at all in the advanced malignancy, it is going to be fixed. Okay, so it can be fixed or mobile, that's a different story altogether. But it is usually going to be a non-tender lymph node. Okay, and in the background of all the infection in the mouth and everything, definitely the answer is reactive lymphadenitis. Okay, so I hope the point is not that reactive lymphadenitis is the answer. The point is that how do you really want to approach the PYQs? This is how you want to approach them, because you want to understand that particular topic in detail, or that particular concept in detail. That is what you really want to do. Okay, perfect. Now, a patient sustained long bone fracture, blah, blah, blah. Okay, now this is something which I have covered very okay, so I usually kind of just breeze through it. This is basically on the ebb and the flow phase. Now, this was asked to you guys, let's say 8 to 10 years back, like 7, 8 years back. I've seen a very, very old question on this, but now they are revisiting this particular topic. So yes, what is this? This is basically a hypermetabolic state. Now, in this particular times recording, which I have done for this particular, the new recording, which I've done very, very recently, I've covered this particular stuff over here. So what does it basically means that when the body is basically suffering from a trauma. So let's take it, let's try to understand this. Okay, so let's say if at all there is an earthquake, what are you going to do? Okay, COVID happened. What did you do? You just stacked up everything, right? I mean, there was a lockdown. So what you did, you just stacked up everything in your home, right? That's what you do. Okay, so what you did, you stacked up everything in the home. Okay, now in the body, if at all, let's say there is a significant trauma, there is an external trauma, or let's say some major surgery is happening, what the body is trying to do, our body is trying to conserve all the nutrients inside it. So what is going to happen, that is what is called as an ebb phase. So this is basically like when that particular trauma is happening, what is going to happen is that the body will enter into the state of catabolism. Okay, so when the trauma happens, the entire body is basically kind of undergoing the state of catabolism. Okay, so that is what you need to understand over here. So it basically Okay. Sorry. My bad over here. Obviously, the answer is not that. So the answer over here is that reduced metabolic rate with decreased oxygen consumption. Okay, that is what is going to happen immediately after the injury. Okay, so as I was trying to tell you that you're going to go into a state where you are trying to conserve everything. So what you're going to do, you will kind of decrease the BMR, because already the trauma has happened. Already what has happened is that all the catecholamines and everything is kind of gone up. So you will decrease BMR and decrease the O2 consumption. That is what is going to happen immediately after that. Okay, immediately after the injury, this is what is going to happen. Okay, so I hope you are able to understand this particular point. So reduce metabolic rate and decrease kind of oxygen consumption, that is what is going to happen. Increased insulin activity and low blood glucose, no, that's not going to happen. We are going to, so there is an insulin resistance which kind of develop over here. Positive nitrogen balance, no, there's going to be negative nitrogen balance, because as I'm trying to tell you that the body will enter into the state of catabolism. And hypermetabolic state, no. Already the body is entering into the state of catabolism. So you yourself will try to kind of conserve all the kind of energy and oxygen and everything. So BMR will basically go down. Okay. So I hope you are able to understand this point. Now, I think it's related to the hypovolemia, blah, 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 blah. Okay. Now, what you need to understand is that after the acute event has happened, okay, after acute event has happened, after let's say 10 days or 60 days or something like that, ultimately you will land up into a state of anabolism where will be a positive nitrogen balance and the growth hormones and all those particular things are going to go up. Are you understanding my point? Now, this is basically a topic of 10 to 15 minutes. Obviously, I'm not covering this at this point, but this is what is the crux of the question which was asked to you. At place, there's a decreased BMR and decreased O2 consumption. Okay, perfect. I hope you are able to understand this part. Okay. Why not tubercular? Because in the tubercular, you're going to get a cold abscess, and just by giving the antibiotics, that particular tubercular abscess is not going to kind of come down. Okay. Now, what is the diagnosis in this particular kind of question? Now, might be difficult for you to read this CT scan in this, but just by looking at this clinical picture, what do you have? You have a swelling on the back of the tongue. So what is this? This is what is your lingual thyroid. Now, 2 to 3 years back, there was a question which was asked you on the lingual thyroid. Your job was to go and read that particular topic in detail. Okay, so that is what I have done very, very recently. Like very, very recently, I covered this, but I did the new recording, and the new recording I have done this. I have kind of covered this lingual thyroid in kind of detail. So as you can see over here, there is a mass at the base of the tongue, and very, very similar. This image was kind of shown to you. This is what is a mass at the base of the tongue, and what is this? This is what is a lingual thyroid. Okay, so now your job is to kind of read this particular topic in detail, because I think they were fed up of asking about the thyroglossal cyst. They thought of asking about some new kind of a topic, and then they have kind of taken up lingual thyroid as one of the things over here. Okay, so I hope you understand this particular point. Now, another prospective question which can be asked to you: before you perform the surgery in the lingual thyroid, what you need to do? You need to perform a neck ultrasound, because you want to see whether the thyroid is there or not. Because if at all the thyroid is not there and you remove the lingual thyroid, the patient will land up into hypothyroidism. Okay, so 70% of the patients have lingual thyroid tissue, blah blah blah. Okay, so I hope you got that particular stuff. Lingual thyroid is an important topic. Go and read that now. Lastly, there were two questions, both based on basal cell carcinoma. It was pretty simple over here. So by the image, you might feel that what the hell is it? But in the description, they had kind of given you all those things. Histopathologically, encapsulated nodular lesion, basiloid cells, blah, 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 everything was pointing towards your basal cell carcinoma. Even the kind of location is very characteristic of the basal cell carcinoma. And right. So what is this? This is basically the basal cell carcinoma with the excision. Okay. Right. So Raj Patel is saying that, you know what, that recording was not for us. I do understand that. But at the same time, when we covered the recall sessions, I have covered the lingual thyroid in detail. I was just trying to show the screenshot because obviously, right, I mean, once the topic comes, then it's our job to kind of teach you guys that in detail, right? Are you understanding my point? But what is your job? Your job is that when you approach a PYQ, your job is to read about that particular topic. Your job is not to know what is the correct answer for that particular PYQ. And even though I've not shared the screenshot of that, but there are times when I have kind of discussed about the lingual thyroid in detail. One of those is basically in your PYQ session, which I conducted the last year as well. Okay, so I hope you got that particular stuff, right? Okay, right. Perfect. Right? Okay. So answer over here is basal cell carcinoma with the excision. That is what is the answer over here. And for the basal cell carcinoma, what you need to understand, excision or that is something which is the answer. Excision. You have to kind of excise the basal cell carcinoma. That is what you need to do. Okay. Now, slow growing kind of nodular growth is seen in this particular image. Characteristic teardrop ulcer. What is this? This is a basal cell carcinoma. Okay, so I think both these particular questions were asked to you. A characteristic teardrop ulcer in this particular region. So I always teach you that, you know what, you join a line between the angle of the mouth and the kind of earlobes. Any particular ulcer above this particular point, that is what is a basal cell carcinoma. Okay, so yeah, that is what is the answer over here. Okay, protein synthesis ebb flow. No, in the ebb flow, there is not going to be a protein synthesis. There's going to be a conservation of the energy. It's going to be a negative nitrogen balance. Okay, let me come back to your this particular ebb flow. In this, what is happening? There is a breakdown. There is a breakdown. So replacement of the lost tissue, that is what is going to happen in the anabolic stage, which is basically the flow phase. Flow phase is again divided into two phases. So in that particular phase, there's going to be the anabolism or the protein synthesis or the positive nitrogen balance is going to happen over here. Okay. What is NCO? Basal cell carcinoma with NCO. What do you understand by NCO? That's fine. No? So basal cell carcinoma with excision, that is what I have kind of told you. Okay. Answer is B over here. Okay. Good, Yummy. Good. Okay. Thank you, guys. That's all. I'm done with this particular session. I know you guys are bogged up, and I hope you kind of had a good time. No point of kind of talking about it, anything. So I hope you had a kind of a decent paper. That's fine. Just chillax now. Wait for the next exam. I mean, you have a INI exam coming up a couple of weeks later, so just wait about that. And yeah, like just live a life. That's fine. And just be grounded. Just try to kind of go through these particular topics or something like that. That will kind of help you. Just continue the efforts. I hope that you get selected this time. If not, if you're really dedicated for this, just continue the efforts. You will reach wherever you want to reach. All the best. Thank you. And yeah, all the best. Take care. Bye-bye.
Hello, dear students. Hello. Nothing has happened. I'm here. We are here to discuss the pedo part of your paper. So, hello, everybody. Okay. Right. So, this is the pedo part. And yes, we have around like 10 to 11 questions from the subject of pedodontics that you had in the NEET exam. And all of them are mostly covered from our notes and the lectures that we took. So let us quickly begin with the questions. The first question that we got from Pedo was, hi, hello. Okay, so this was the first question that we've got. So it was an IBQ, it was an image-based question, and it was about it. A radiograph was given, and a child presents with caries in a deciduous molar. Okay, so you all can see there's a radiograph given, and there were caries in the deciduous molar. So this is the carious deciduous molar. This is a 4, or let's say a first primary molar that's looking carious. And what is the most appropriate treatment? Okay. Yes. So they've asked the most appropriate treatment. Now, very carefully, if you look, the first permanent molar is still unerupted. That means the age of the child whose radiograph they would have given is less than 6 years. So a child who is less than 6 years, okay, the screen is not seen. Is it the same for everybody? Please confirm so that I can continue. All right. So Namrata, if this was not the similar radiograph, can you tell me a little bit what sort of a molar was given in the radiograph? Because according to this radiograph, the radiograph that we've procured, here the the roots of the teeth are still there, and the child is less than 5 years old. So according to this radiograph, we'll best go for restoration and a stainless steel crown, because the pulp does not seem to be involved in this radiograph, and it is best to go for a restoration and stainless steel crown if this is the condition that was given. Okay, it's visible. Just kind of zoom it out. Okay, so if you look at the age of the child, this is less than 6 years of age. Okay, because the first permanent molar is still unerupted. Okay, if you look at the deciduous molar that is carious, the pulp is uninvolved in this radiograph. So we'd best go for restoration. And why not GIC? Because the caries that we can see is a proximal caries, and as we had read in our lectures, it is best to give a full coverage restoration in case of proximal caries when we have proximal caries in case of deciduous teeth. So, okay. So in case the roots were completely resorb, then you go for extraction. Okay. In case the roots were there, like in the case of this radiograph, the roots are still present. So I would go for restoration with stainless steel crown. But if the roots are completely resorbed, then you go for an extraction. Okay. Okay, so I have one more question where there is an extraction and band and loop. Let us just move further and we'll compare whether that was the question present or this was the question present. But since there is a root here, we go for restoration and stainless steel crown. And it's been given in the notes that stainless steel crowns are basically used for, the caries that are present where there is gross decay of the teeth. Okay. Okay, so somebody is in real hurry. So the second question was, the child is under conscious sedation and how does the child respond during conscious sedation? And this was a video question, and there was a video where a dentist is speaking to a child and the child is responding by raising the hand. Okay, and they had asked, how does a child respond during conscious sedation? And these were the options. So if these were the options, then the answer is The patient is aware aware and responds to the verbal commands. Okay. In conscious sedation, the patient does respond to the verbal commands. This is a straight pick from our notes where it says that conscious sedation produces a state of depression of the nervous system, enabling the treatment while maintaining verbal contact. So the patient does respond to the verbal commands. Hence, the patient is raising the hands by responding to the commands. Okay. Yes. Okay. Now, the question number 3 was, a model is given. This was the given image, and they had asked which theory of child psychology describes about this model. So this model is called as the topographic model. Okay. So this is the topographic model that is there. And the topographic model is that of Freud. So the answer here is Sigmund Freud. Again, we had read in great detail about the topographic model, Freud's theory of psychoanalysis, or the psychosexual theory that was given by Freud in the year 1905. He spoke about the psychic triad, the topographic model, and the stages of the and the various stages that we had read. So topographic model is that of Freud. Okay. Yes. The next question was, so this question, a 5-year-old child has bilaterally missing first primary molars. Okay. So, so they had given a mandibular arch picture with bilaterally missing first primary molars. Which of the following space maintainer is indicated in this okay, in this? And yes, you guys are in real hurry. Somebody saying please go fast, somebody saying please go slow. So, just let me do it my way. So there was this question where they had given a mandibular arch where 2 primary molars were missing. And they had asked what type of a space maintainer must you give there. So because they had given the age is 5 years old, that means the permanent incisors are unerupted. Okay, so the permanent incisors are unerupted. That is why we cannot give a lingual arch. So generally when there is bilaterally missing lower molars, primary molars, we give a lingual arch space maintainer. But because the permanent incisors are unerupted, we will give a bilateral band and loop space maintainer. So you will go for a bilateral band and loop space maintainer here. So the answer is bilateral band and loop if they have given a primary molars missing with no permanent incisors. Okay. Yes. Okay, again, this is from the notes where we had said that it can be given bilaterally if the permanent teeth are not present. Then you can give bilateral band and loop. Okay. The next question was, what would be the best treatment for an Ellis class 2 fracture in a 7-year-old? So a 7-year-old patient is there and Ellis class 2. That means a fracture that involves enamel plus dentine. Okay. So generally in a class 2 fracture, we give a full coverage crown. That's a permanent crown. But since they've given a child age as 7-year-old, so in 7-year-old, the second permanent molar does not erupt. So until and unless the second permanent molar erupts, you cannot give a permanent crown. You cannot give a zirconia crown. You cannot give a metal ceramic crown because you need to allow the jaw growth. So in this case, you will go for light cure composite. You will not go for a stainless steel crown because it is an anterior tooth. You will not go for a GIC, not a zirconia, but you will go for light cure composite because they have mentioned a 7-year-old. Okay. So you will go for a light cure composite here. The next question, there was a picture of a child that is given and there was a radiograph where there is a grossly decayed 5.4 was given. So they had asked there's a grossly decayed primary molar and they had asked the best treatment option. So when there is a grossly decayed primary molar with no roots, so here you all can see there is almost no roots present because of the decay. So here you will go for an extraction with a band and loop space maintainer. Okay, so you will go for a band and loop space extraction and a band and loop space maintainer here. Okay, the next question was, a 5-year-old child has an avulsed tooth. What is the best treatment option? Okay, even if the age is mentioned. So, right. So the answer here is extraction with band and loop space maintainer. Now, 5-year-old with avulsed tooth, what is the best treatment option? Now, the tooth is avulsed. We have read during our lectures that we never reimplant a primary tooth. 5-year-old, matlab he will have all the teeth as primary. So, whichever tooth has avulsed, which probably they have or not mentioned, but every tooth is going to be a primary tooth, and you never reimplant a primary tooth because it causes harm to the permanent tooth bud. So the answer is you should not replant a primary tooth. The answer is no replantation. The answer is D, generalization. Next question is, a dentist while excavating caries exposes pulp by mistake. Which pulp capping agent would he use? Okay, so because they have said that the dentist is excavating caries and he exposes the pulp by mistake, that means he has mechanically exposed the pulp. Mechanical pulp exposure is generally an indication for direct pulp capping, and for direct pulp capping you go for calcium hydroxide. C, calcium hydroxide is the answer. Okay. Okay, so the answer is C, calcium hydroxide for direct pulp capping. If they had mentioned pulpotomy, so that's again a confusion. Some say that it was pulpotomy was given. If they had not mentioned pulpotomy and if they had asked about the pulp capping agent, you go for calcium hydroxide. Agar question में pulpotomy लिखा था, then you go for formocresol. Okay, was pulpotomy mentioned in the question? If the pulpotomy word was mentioned in the question, then you go for formocresol. Okay. And if it was only, they had said that there was a mechanical exposure or pulp exposed by mistake, then you go for calcium hydroxide. Right? Okay. Now, question number 10 was, a permanent incisor sustained a trauma and became non-vital. So it had become non-vital. What is the treatment for such a tooth? It is a permanent tooth. It is a young permanent tooth. You all can see the apex is open. So undoubtedly, you will go for an apexification. Permanent tooth, it is non-vital and it has open apex. You go for apexification. ठीक है. If pulpotomy was mentioned, Rashmi, then you go for formocresol. Okay, right. Then it is formocresol if they had mentioned pulpotomy in the question. So this is apexification. I hope this is this everybody has gotten correct. Apexification is the answer here. And then the 11th question is, a tooth suffered trauma and the radiograph shows ragged borders of the roots. Which of the following is the condition? So trauma and ragged borders of the roots, it's a clear-cut indication of external inflammatory root resorption. That is EIRR. That's an external root resorption that causes because of trauma, because of harm to the PDL cells, which result in clastic cell development, resulting in EIRR, that is external root resorption. So the answer here is B. Okay, that is external root resorption. Yes. So that's it. These were all the questions that we procured for Pedodontics. I hope you've got them correct. And all right, then all the best for the further questions. Thank you so much. Bye.
All right, so a very good afternoon, everyone. So am I audible and visible to all of you? Yes. All right, thank you. Sure, we'll start with the medicine questions. So many of the questions were from the notes, right? I will try to show you the screenshots also, like where they are in the notes. And at the same time, yes, the questions were slightly lengthy, right? They have scared you a lot in the exam, but the questions were very simple. They were completely directly from the notes, right? But only thing is you need to identify where exactly the answers are in the notes, okay? Right. Now, so let us start with the first question. So the first question is, right. So we have a 6-week-old child who was taken to the hospital for routine pneumococcal vaccination when the pediatrician gave him the conjugate vaccine. Okay, what the pediatrician is given? Conjugate vaccine. What is the advantage of this vaccine over the older polysaccharide vaccine? Number one, the first option. Right. So the first option, they bypass the T cell immunity and act on the B cell and make IgM. They directly act on plasma cells, CD4 cell activation, major histocompatibility complex activation, and CD8 cells. So yeah, what did you people answer? What is the advantage of the conjugate vaccine? Right. So now let me tell you. So conjugate vaccine is that it will activate the CD4 cells. Okay. Conjugate vaccine, it will cause the CD4 cell activation. Right? CD4 cell activation. Now, why not the other options? I will tell you. Why not the other options? I will tell you here. Okay. Now, you take the T cell, they bypass the T cell immunity and act on B cells and make IgM. So, which particular vaccine is T cell independent? See, they bypass the T cell immunity, right? They bypass the B cell immunity. That means it is T cell independent. So, which one is your T cell independent? It is polysaccharide vaccine. Understood? Now, your option A is out. You take option B. Option B, right? They directly act on plasma cells. Remember, no direct plasma cell activation without immune processing. So your B is out. And your MHC activation and CD8 cell, they have cytotoxic response. They are not at all relevant here. So the correct answer is what? That is CD4 cell activation is the correct answer here at this point. And you can see in the notes, right? So you can just see here. Okay, so this is like polysaccharide vaccine and this is the conjugate vaccine. So what is being preferred now? The conjugate vaccine is what is being preferred now. So this is directly from your notes. Now, coming on to the next question. 29-year-old female type 2 diabetes, overweight, BMI 29, shows this clinical characteristic features. What is the diagnosis? So what is this particular dark velvety skin? This dark velvety skin in a patient with type 2 diabetes mellitus, it is a feature of the insulin resistance. So that is suggestive of the acanthosis nigricans. And in case of hemochromatosis, you don't have this pigmentation over the nape of the neck, right? The pigmentation will be there over the face. Pigmentation will be there over the face. So the answer is the acanthosis nigricans. So you can just see in our notes, it is directly from our notes, the avascular complications in case of diabetes mellitus will be acanthosis nigricans, right? It is there in our notes. Now, moving on to the next question. So you take type 2 diabetes mellitus, it is the insulin resistance is primarily due to which of the following mechanisms, right? Antibodies against beta cell that is observed in case of type 1 diabetes mellitus. Antibodies against the alpha cells is not observed in case of diabetes mellitus. And the peripheral insulin resistance, that is the important point for the development of insulin resistance. So where will be the insulin resistance? Over the liver, over the adipose tissue, over the skeletal muscle. And increased glucagon secretion is nowhere related to your insulin resistance. So the answer to this particular question is what? That is, the peripheral insulin resistance is the answer for this particular question. Done? Now, moving on to, yeah, you can see this, right? So the insulin resistance in case of type 2 diabetes mellitus, it is peripheral, right? And this is directly from our notes. Done? Now, moving on to the next question. Right, moving on to the next question. So a patient presents with hyperpigmentation of sun-exposed skin, pigmentation of the palate and as well as tongue, and craving for salty food. What is the most likely diagnosis? So what is the clinical condition where you will have hyperpigmentation and craving for salt? That is observed in case of the Addisons. In case of Addisons, you have aldosterone deficiency, because of which there is hyponatremia, and that is the reason why they will be craving for salt. And why is that they have hyperpigmentation? That is because of increase in ACTH, and that is the one which is causing increase in the MSH. Right? In hemochromatosis and all, you might be having hyperpigmentation, but the very important point here is like craving for salty food. Craving for salty food is making the answer completely going towards the Addisons, right? And yeah, so even this is also directly from our notes. Now, moving on to the next question. So we have a patient presenting with a painful vesicular rash over the abdomen distributed along the lumbar dermatome. This point is very clear. Lumbar dermatome. The patient gives a history of chickenpox in the childhood. What is the most likely cause of this particular condition? Right. So any one of you, what did you people mark here? So always remember the chickenpox, it is not a new virus infection. It is always reactivation of the latent herpes virus. And what is that? It is your varicella zoster virus along the dermatome. So what are these? These are your vesicles. How are they? They're very painful and they are grouped vesicles. And there is also history of chickenpox in the childhood. That tells that there is activation of the latent herpes or the varicella zoster virus, right? So it is not the new infection, right? And it is not associated with this particular hematogenous spread. Whatever the virus which is latent, that gets activated whenever the individual immunity is like compromised. Okay, so the answer is A in this question. Now, coming on to the next one. So 60-year-old chronic smoker, very important, right? Chronic smoker, weight loss, anorexia, loss of appetite, persistent cough, and there is also clubbing. What is the most likely diagnosis? So what did you people mark for this? So the answer for this is what? It is your bronchogenic carcinoma. It is not your tuberculosis. Why? Because in tuberculosis, it is not mandatory that the clubbing should be there. It is not mandatory that there should be clubbing. And in case of bronchiectasis, they don't present with weight loss. Okay, bronchiectasis weight loss does not go both. And even you have pneumonia also. Even in case of pneumonia, it is not mandatory that there should be clubbing and as well as weight loss. So with a background history of chronic smoking, weight loss, loss of appetite, all these, they point towards your bronchogenic carcinoma. So the answer is C in this particular question, right? So this is also given in our notes, right? So almost all, I can tell almost 90% or completely from the notes. Now, moving on to the next one. A patient presents with markedly constricted pupil that does not react to light but constrict during the near vision. And there is history of syphilis. What is the most likely diagnosis in this scenario? So what did you people mark here? There is no constriction to light, but there is constriction during the near response. What does that mean, constriction during the near response? That means constriction during the accommodation. So the answer to this particular question is the accommodation reflex is present, but the pupillary response is absent. Okay, light reflex is absent. So what is the answer here? It is Argyll-Robertson pupil. And the other important history which tells you it is an Argyll-Robertson pupil is the syphilis, right? So there's a background history of neurosyphilis that tells it is your Argyll-Robertson pupil. Now, why not Horner's pupil? Horner's pupil, it is characterized by a triad, and that particular triad include, there will be like meiosis, ptosis, and as well as anhydrosis. This is a triad in case of the Horner's pupil. And next is the irregular pupil. Irregular pupil does not explain the light near dissociation. You don't have any accommodation reflex in case of the irregular pupil, right? So the answer here is the Argyll-Robertson pupil. Now, moving on to the next one. So we have 2-year-old child presented with delayed walking and as well as bowing of the legs. And there was widening of the wrist. The wrist showed cup-shaped defect of the metaphysis and splaying of the borders. What do you think is the diagnosis? Yeah. So what did you people answer for this? There is there is a classical description that there is a cup-shaped defect and that too in a 2-year-old child. So the answer in this particular question is what? Rickets. So 2-year-old child, delayed walking, bowing of legs, widened wrist, metaphyseal cupping, fraying of metaphysis. All these are the features of your rickets, right? It is not your osteoporosis, because in osteoporosis you will have like decreased bone density, but there is no metaphyseal cupping. And it is not your osteomalacia, because osteomalacia is what? It is an adult counterpart of rickets. But here what is given is a 2-year-old child. And it is not your scurvy, right? Scurvy, it shows white line of Frankel or pelican spurs, but you don't have cupping in case of the scurvy. So that is the reason why the answer is not scurvy. The answer is what? Rickets. Done. Moving on to the next question. We have a patient with known abdominal pain, fatigue, and as well as hepatomegaly under the costal margin. And the examination as shown in the image, right, where there is presence of the icterus. He comes to the dental OPD for tooth extraction. Which of the following investigation should be performed prior to the procedure to assess the bleeding risk? Right, very clearly question given is the bleeding risk. Okay. But so yeah, even though if the pelican spur is given, even though the pelican spur is given, in case of scurvy, there should be white line of Frankel, right? But cupping, if it is given, it is not at all scurvy. If cupping is given, it is not at all scurvy. If cupping is there, metaphyseal cupping is there, that is suggestive of your rickets. Okay, right. Now, yeah, so in this question, the answer is what? In this question, it is your PT and as well as INR. Because the PT and INR, this is the best indicator for the liver synthetic function. That will reflect your factor 7. That will reflect your factor 7. And why not your ALT or AST? ALT and AST will indicate the liver injury. They don't indicate the bleeding risk. And why not your APTT? APTT, it will tell you about the intrinsic pathway, right? It is very much less sensitive early in the liver disease. And your AG ratio, that will tell you about the chronic liver status, but not about acute bleeding risk. So that is the reason why your AG ratio is ruled out. Okay. Right. So the one which is telling you about the bleeding risk is what? That is the factor 7. And not only that, the half-life of factor 7, it is also having a short t-half. So the one which will tell you about the acute bleeding risk is your PTN as well as INR. It is not your APTT. Done? Next. Then we have a patient with liver disease presenting to the dental OPD for tooth extraction. The patient had icterus, pallor, and hepatomegaly. Which of the following abnormalities is most likely responsible for increased risk of bleeding in this patient? Liver enzyme deficiency, deficiency of the clotting factors, vitamin C deficiency, and as well as thrombocytosis. What do you think is the answer? What did you people answer here? Right. So the answer here is deficiency of the clotting factors. See, liver is the one which will synthesize most of the coagulation factors 2, 5, 7, 9, 10, and as well as 11. And if there is liver dysfunction, there will be decrease in the synthesis of the coagulation factors. Now, why not other options? Right. You take first option. That is liver enzyme deficiency. Enzyme deficiency will reflect the hepatic injury, but that does not tell you about the bleeding mechanism. Right? Why not your option C? Option C is what? It is like scurvy. It is not the primary issue here at all. And option D, thrombocytosis, would actually lead to clotting, not bleeding. If there is thrombocytosis, there will be clotting, but not bleeding. So that is the reason why the answer is B in this question. Chalo, okay, this was not the, okay, I'll show you the exact ECG. Just give me a minute. Yeah, this was the exact ECG. So tell me, what is the diagnosis of this ECG? Coronary artery disease, unstable angina on dual antiplatelet therapy, atorvastatin. The patient is on beta blocker, now presenting with dizziness. ECG shows the following. What will you do? Decrease antiplatelets, decrease statin, decrease beta blocker, immediate angiography and stenting. So what do you think is the diagnosis of this ECG? Anyone? Diagnosis of this ECG? So if you are able to make out the diagnosis, then you will be able to make out the answer for this question. I'm waiting for, no, it is not STEMI. It is not STEMI. It is not old MI. It is not old MI. Yeah, Vidyavatri, your answer is correct, but you should tell the diagnosis of the ECG. It is not STEMI. Right. So, very good. So, Pranav Kumar Ravi, excellent. So, this is the ECG of complete heart block. This is the ECG of complete heart block. Okay. So, you have a P wave, you have a P wave, you have a QRS complex. And this is a P wave, this is a P wave, this is QRS, this is P, this is P, this is QRS. So what is that you should understand here is, you should understand that there is no atrioventricular association. There is AV dissociation. Right? There is AV dissociation. Now, if at all, if there is AV dissociation, that is called as a complete heart block. And whenever there is a complete heart block, you need to decrease the beta blockers. You need to decrease the beta blockers. Okay. So the answer is C in this question. Now, moving on to the next one. So, chronic alcoholic patient presenting with dyspnea and cough. On examination, there is bronchial breath sounds are heard over the left lower lobe. The patient produces thick blood-tinged sputum, and which is red currant jelly. What is the most likely causative organism? So, what do you think the most likely causative organism? The most likely causative organism, if there is red currant jelly, it is suggestive of the Klebsiella pneumonia. It is suggestive of your Klebsiella. It is not Mobitz type 2. It is not Mobitz type 2. Okay, it is a complete heart block. Chalo. Now, so in this question, right? So what is that you are having? You are having the presence of red currant jelly. And why not the other options? You take the Legionella. Legionella, you have atypical pneumonia. It is like you don't have the sputum at all. You don't have the sputum at all in case of the Legionella. Whereas in case of Streptococcus pneumonia, you'll have a rusty sputum, right? And in case of Haemophilus influenza, the quantity of the sputum is very mild. So the answer here is Klebsiella because it is presenting with red currant jelly. Done? Then followed by that, yeah, you see the next one. We have a 22-year-old patient presenting with fatigue and reduced concentration, and routine hematological workup suggests anemia. And iron studies reveal. So basically, like, what is this now? Iron deficiency anemia should be there. In iron deficiency anemia, what happens? There will be decrease in the ferritin. There will be increase in total iron binding capacity, right? And there will be decrease in serum iron, and there will be increase in the transferrin levels as well, right? Increase in the transferrin levels as well. Okay. So now you take the other options. Why not the other options? So increase in ferritin, decrease in total iron binding capacity, right? This is not the picture that you'll have in case of iron deficiency anemia. In an iron deficiency anemia, it is decrease in ferritin, increase in total iron binding capacity, increase in serum iron, and increase in the transferrin levels. Okay. So this is about the option A. Yeah. So these are the questions related to the general medicine, right? And only 3 parameters were given. Okay. What was not given? They didn't mention about. Oh, chalo. Okay. We will take out the transferrin. Right. We'll take out the transferrin, no problem. So even we take out the transferrin, right? The answer will be decrease in ferritin, increase in total iron binding capacity, and increased iron. So decrease in the iron. So this will be your picture that you'll have in case of the iron deficiency anemia, right? No problem. Even if you take out transferrin, still the answer will be your A. Okay. So these are the questions related to the medicine, right? So the next educator is waiting for the recall. Okay. So I'll just wind off this particular session of recall related to medicine, right? So any doubts you can just ping on the Telegram channel. I'll be definitely there to help you all in clearing your doubts in detail, right? As the next educator is waiting, so we'll just let over the other educator take up the next important recall session. Thank Thank you very much.
Yeah. Welcome to all of you, and thanks, Dr. Kuba. What a nice session. Like my medicine is also refreshed somewhere.
Thank you, sir. Thank you, sir.
Right. Fine, sir. Now I'll take over this thing, right?
Yes, sir. Yes.
Okay. Okay, so guys, welcome to this pharmacology session. Thanks, Dr. Kuba. What a nice session. Right. So I am there with you people on this YouTube live videos. So in case you have any doubt, please ask me directly whenever we display any question of pharmacology. And also, here the main purpose is not to teach you anything. Here the main purpose is to just to tell you the questions which are asked in the exam, and also try to recall all the four options which were there in the exam, right? Okay, yeah, hi everyone. Yeah, so starting with question number one. So if we talk about the pharmacology, like I have discussed with students also, the level of pharmacology was easy. So if you ask me, sir, the overall paper level was medium to bit difficult. But if we talk about the pharmacology part was comparatively easy. So more than 90% questions directly come from our notes, and also directly come from the important topics which we have suggested you to read. And total approximately 15 to 16 MCQs have been asked from pharmacology. Now, out of this 15, 17, 16 MCQ, you will find out the most of the questions have come from autonomic system. So whenever we teach you pharmacology, we always take this autonomic nervous system as a first topic. So most of the questions have come from here. After that, the questions have been asked from central nervous system. So I don't know why the examiner is so fond of this nervous system in the body. So autonomic nervous system, central nervous system, and little bit of cardiovascular system. These three topics are mostly asked, right? So these three topics are mostly asked: ANS, CNS, and CVS, right? Total 15 to 16 questions. Okay, so many of you are answering, when many of you saying that you have attended my RR rapid revision and you were able to answer my question. Okay, yes. Yeah, I know that the overall paper was medium to difficult, but the pharmacology was easy. So without wasting much of your time, you people have to help me out only one thing. Whenever I display any question, in case the options are not matching with the options which were asked in the exam, you have to just tell me, sir, this option was not there, this was the option, right? Right. Okay. So let's start. So starting with question number one. So this question was based on hematology. So first question was from hematology. So in hematology, the question was a patient was having a DVT, was started on heparin therapy, and few hours later he develops the bleeding. So it's a heparin toxicity. Now, which drug will be most appropriate to give the management? So they have asked you the heparin antidote. So heparin antidote is directly answered the protamine sulfate. The other option is vitamin K, which was there in the exam. And according to some students, instead of vitamin A, the option was vitamin C. So here you people have to help me out, whether it was vitamin A or vitamin C. And the fourth option was tranexamic acid, right? So can you please tell me whether it was tranexamic acid or the cryoprecipitate given? So according to some students, it was cryoprecipitate. According to some students, it was tranexamic acid. So what was the option, guys? Was this vitamin A there in the option, or vitamin C was there in the option? Okay, vitamin A was there in the option. So I'm just removing this vitamin C. So vitamin A was there. So I'm removing vitamin C. Okay, now was this tranexamic acid given or cryoprecipitate was given? Tranexam was there. No cryoprecipitate, because some students have told me uh, protamine sulfate was not there. Tranexamic acid was there. Uh, Guys, protamine sulfate was there or not there? Yes, fast we'll do. Dr. Sandalwood, don't worry, we'll do fast. But here you have to help me out in finding the proper options which was there. So tranexam was there. Cryoprecipitate was there or not there? Cryoprecipitate. Okay, protamine sulfate was not there. So if the protamine sulfate was not there in the MCQ, then the cryoprecipitate will be the answer. And this will be the answer then. If protamine sulfate was not there, then cryoprecipitate will be the answer. Or if protamine sulfate is there, the protamine sulfate is a better answer. Okay, so most of you are saying protamine sulfate was there. Okay, so this was the clear-cut answer. And tranexamic was also there according to you. So this was the exact options which were asked in the exam. So question number 1, answer is A. Now, this was the question directly picked up from our notes. So I have just taken the reference of our notes also. So you can see this is the screenshot we have taken from our notes, and we have discussed this protamine sulfate. So this protamine sulfate is the antidote of choice for heparin toxicity. This is direct taken from page number 68 of our notes. Now moving on to question number 2. This was based on status epilepticus. The patient was undergoing some treatment and patient got status epilepticus. What is the drug that used to be there? Which drug is used here? So answer is lorazepam. So one option was lorazepam. So this was the direct answer. One option was valproate. Now, can you please tell me the other options were topiramate or carbamazepine there in the MCQ or not? Topiramate was there or not there? Can any one of you confirm me? Topiramate was there or not there? So this question that is based on status epilepticus, again taken directly from our notes. You can see the page number 104. So page number 104, this question has been taken where we have specially mentioned that lorazepam. So lorazepam is a drug of choice for status epilepticus. This is what we people have covered already. Okay, so this was the answer. Lorazepam was the answer. Topiramate was there. According to you, topiramate was there. So these were the 4 options asked in the exam. So question number 2, answer is A. Right. Now, question number 3, a strawberry farmer presented to you emergency department with profuse salivation, abdominal cramps, diarrhea, lacrimation. So it's a organophosphate poisoning. So this is a case of organophosphate poisoning. So I told you whenever, like this thing we have discussed during our lecture also, whenever we talk about any farmer, we always talk about the organophosphate poisoning or the pesticide poisoning. So they have asked you the antidote of choice. So the antidote of choice for this poisoning is atropine. So atropine is the antidote of choice. The other options were physostigmine, neostigmine, naloxone. I just want to know whether this naloxone was there in the MCQ or not. So naloxone was there in the MCQ or not. So atropine was the clear-cut answer. And this is again taken directly from our notes. You can see this is the autonomic nervous system notes, and we have discussed that atropine. So it's mentioned there that atropine is an antidote of choice. So it's a clear-cut answer directly taken from our notes. So atropine is the clear-cut answer. So naloxone was there according to you. So this was the 4th option. Okay, so answer is atropine. Question number 3, answer is A. Right. Okay, let's move on to question number 4. A 3-year-old child brought to the emergency department after ingestion of large number of iron tablets. So this is a iron toxicity. This is the case of iron toxicity, and they are asking you what is the best management. So what is the best management of iron toxicity? So answer is desferoxamine. And this also we people have discussed so many times during our lecture. And these were the other option, penicillamine given for copper, and also this you people can read by yourself. So here I have to tell you the answers only. So question number 4, answer is A, desferoxamine is the answer. And you can see this is again directly taken up from our notes. You can see this is iron toxicity written here, and the drug of choice is desferoxamine. So this is how these questions are directly picked up from our notes. So desferoxamine is the answer of this MCQ, right? So calcium was there. According to you, there was a calcium. So which option was not there, guys? You are saying calcium is one of the option. So can you please tell me which option was not there? So one option was calcium, but which option was not there? Anyone can answer? Which option was not there out of these 3? Penicillamine, EDTA, dimercaprol. So which was not there? Anyone can answer? And right, don't fight with each other, yeah. It's time for fun. Like you have already given the exam, you are relaxed. So let's enjoy. Whatsoever anybody is saying, please accept it. It's time for the fun. Okay, EDTA with calcium is given. So, okay, they have given the EDTA with calcium. So EDTA with calcium is given. So the answer is okay. So all were there. So EDTA with calcium was written. So answer is desferoxamine. Now let's move on to question number 5. A 5-year-old child with fever during an influenza outbreak was given as antipyretic drug. So was given an antipyretic medicine. The patient has got abdominal pain, nausea, vomiting, irritability, behavioral changes, and some features of hepatic like bleeding was there, and there was a tenderness. So tenderness in the hepatic region. So hepatic tenderness, bleeding was given. Now which drug is responsible? So this was like here there's a confusion. Aspirin is the answer. It's a case of Reese syndrome. So this is a patient of Reese syndrome, right? I just want to know whether they have written this influenza outbreak or not. So influenza outbreak was written or not written. Whether they have given the child has got a viral fever or the viral infection. So influenza outbreak was written in the exam or not written. So it was written in the exam that viral outbreak was going on and he has got an infection because of virus. Because in viral fever, if I give aspirin, the child can have the precipitation of mitochondriopathy. The child can have precipitation of mitochondriopathy. So, okay, so it was not mentioned. So this is what this is what the confusion is. According to some student, this was not written. So according to some student, this was not written. Now you people have to tell me if this influenza outbreak is not written. Can you please let me know whether this nausea, vomiting, irritability was written or not written? Because according to some students, it was only written as कि patient का जो liver enzymes थे, liver enzymes are raised. Patient will have the bleeding tenderness. Okay, so anyone can answer. So where influenza outbreak was not written, the child was having a fever and you had given antipyretic. Now, can you please tell me nausea, vomiting was written or not written? Nausea, vomiting was there. Okay, so nausea was there, vomiting was there. Hepatic encephalopathy symptoms में students have told me कि they have written कि hepatic tenderness था. So patient was having a hepatic tenderness, bleeding was there, liver enzymes were elevated. So and it's a acute case basically. So we can rule out acetaminophen poisoning. So acetaminophen poisoning where the some history was not there. So aspirin was the correct answer. It's a case of it seemed to be a Reese syndrome, right? So question number 5 directly taken from our notes. You can see this is the screenshot from our notes and we have written here that the patient can develop the Reese syndrome when he will take the aspirin. So aspirin can cause Reese syndrome. This was written over here. So this was the case, right? So hepatic encephalopathy word was written. Okay. Now question number 6. You can see patient is undergone some surgical procedure. Now he has got he has been prescribed some post-operative painkiller. Now he has got a nausea. So two symptoms were given, nausea and constipation. So he has got a nausea and constipation. Now they are asking which drug is responsible. And now, so this we have discussed during our lecture also that opioids. So opioids most common side effects. Opioids most common side effect is nausea and vomiting. And one of the most important side effect which was asked in your dental exam also that constipation is one of the important symptom caused by the opioids. So opioids can cause severe nausea, vomiting. Opioids can cause constipation as a side effect. So codeine is the answer in this MCQ. Answer is A. Right. So A was the answer of this MCQ. So this is based on opioid side effect. So I don't have the screenshot with me, but this we have discussed so many times during our exam. And this is also your PYQ actually. So there was a PYQ कि opioids में tolerance is not seen against which action. So that was the answer. Constipation was the answer of that. Right. So this was the answer. So Dr. Yoga is asking, Yoga Darshini is asking one question. Which drug could have been given? Okay. So इसमें था कि which drug could have been given. So this is the same thing. Which drug could have been given? So which drug is responsible or which drug could have been given? Last point. So aspirin was the answer. Okay. So question number 6, answer is codeine. Now let's move on to question number 7. So question number 7 mein a diabetic patient was given. He is having a CKD and now he has undergone renal transplant because of diabetic kidney disease. Now he has come to you with gingival enlargement, right? Now which drug is responsible? So answer was cyclosporin. So cyclosporin is a drug that is given after kidney transplant. So after kidney transplant, cyclosporin is one of the drug that is given and this medicine can cause gum hypertrophy. Now here the confusion is you have to tell me about the other options. You have to tell me about the other options, right? इसमें बताओ which drug is mostly responsible. Cyclosporin was there. According to some students, corticosteroid is written. Corticosteroid is written. And students are saying that nifedipine is not there. Nifedipine was there or not there? Yes, one option is corticosteroid. Yes, Dr. Harshita, that's correct. Now, can you please tell me nifedipine was there or not there? One option is, according to some student, यहाँ पर sulfonylurea लिखा था. But sulfonylurea is not an immunosuppressant. So here the names of immunosuppressants would be there. सल्फोनिलुरिया तो बच्चे एंटी डायबिटिक है, तो एंटी डायबिटिक हैज नथिंग टू डू हियर. मतलब यू वांट टू से कि डायबिटिक पेशेंट था तो ही इज ऑन सल्फोनिलुरिया. So in case the sulfonylurea was written, so which was there, sulfonylurea or sulfasalazine? Because sulfasalazine is immunosuppressant, sulfonylurea is an antipyretic. And nifedipine तो sure shot नहीं था. Nifedipine was not there. Guys, was there any drug written like tacrolimus? Like, was there this drug written in the exam? Tacrolimus. So tacrolimus is very similar to cyclosporin. So nifedipine I have removed. You people are telling me nifedipine. Okay, phenytoin was there. So phenytoin, according to you people, it was there. The phenytoin, in this case, there is no relation. Patient is not having a seizure, right? Okay, according to you, sulfonylurea ही था, sulfasalazine नहीं था. So I am removing sulfasalazine. I am writing sulfonylurea. So phenytoin was there according to you. So tacrolimus was not there according to you. Tacrolimus was also not there. Phenytoin was there. So phenytoin has nothing to do here because the patient is not a case of not a case of epilepsy. So phenytoin का कोई point नहीं है यहाँ पे देने का. Okay, if anyone can able to recall, according to some of you, phenytoin was not there. So in case you are able to recall, what was the third option? Let me know about this. Okay, guys. Okay, Dr. Shruti कह रही है tacrolimus. Tacrolimus was there. So guys, please let me please confirm me about this option. Okay, cyclosporin was the correct answer. Okay. Okay, let's move on to question number 8. Question number 8. Patient has taken some overdose and planned for hemodialysis. Now, which of the following property of drug makes it amenable to remove by the hemodialysis? So here the answer is A. If the medicine is having a low volume of distribution and the low protein binding, then hemodialysis is possible. Now, this question is also directly taken from our notes. So during our notes, we have discussed this thing. So this was the screenshot of our notes, and you can see we have clearly given this point. Hemodialysis is only successful. The criteria for hemodialysis, if the plasma protein binding is less and the lipid solubility is also less. So lipid solubility means volume of distribution. So if the volume of distribution is less, lipid solubility is less, plasma protein binding is less. So this question directly picked up from our notes. So patient, if the medicine has low volume of distribution, low plasma protein binding, then hemodialysis is successful. So this we have already covered in our notes as well. So directly taken from our notes. So question number 9. Can you please let me know whether this question was actually asked or not? So question was based on Parkinson's disease and they are asking why we use carbidopa. So this question was there or not there? Can you please confirm me? So carbidopa, what the carbidopa can do? Carbidopa will inhibit the peripheral dopa decarboxylase enzyme. And by inhibiting the peripheral dopa decarboxylase enzyme, levodopa cannot be converted to dopamine. So this will inhibit peripheral conversion of levodopa to dopamine. So this question was there according to you. So this question was there. So carbidopa is a drug. This will directly inhibit the conversion of dopa to dopamine by inhibiting the dopa decarboxylase enzyme in periphery. Now again, I would take the credit of this thing because we people have discussed this question in our notes, in our class also, right? So this was directly taken from our notes. You can see this is the screenshot for our notes. And this is the carbidopa. So you can see carbidopa given for Parkinson's disease. The basic purpose is this is inhibitor of dopa decarboxylase enzyme. So carbidopa inhibiting dopa decarboxylase inhibit the conversion of dopa to dopamine. So instead of writing dopa, they have given you levodopa. So dopa to dopamine conversion is inhibited by inhibiting the peripheral conversion that is done by the carbidopa. So this is directly taken from our notes. Okay. So question number 9, answer is C. Carbidopa inhibits the peripheral dopa decarboxylase and therefore this will inhibit the peripheral conversion of levodopa to dopamine. I know there is some confusion here because option A is almost the same thing, but I found it incomplete. You can see if you read the option A, carbidopa prevents peripheral conversion of levodopa to what? So this is an incomplete statement. This is an incomplete statement. So in case this C option was not there, in case this C option was not there, then the answer would have been the A. In case the C was not there, the A would be the answer. So guys, have you got the concept? Like my basic purpose is to come here to give you the concept. Have you got a concept? Like this medicine is inhibitor of dopa decarboxylase and inhibit the conversion of levodopa to dopamine. So agar ye option C was not there in the exam, so the option A would have been the answer, right? So levodopa to dopamine, if this statement is given like this way, So C is not there, then the A is the direct answer of this MCQ question 9. Let's move on to question number 10, guys. So we talk about question number 10. A patient is undergoing the dental procedure, suddenly felt the lightheadedness, and he has got a AV block. So he has got a AV block, which is also known as the heart block. Now they are asking, what is the drug of choice? What is the drug of choice for heart block? Okay, इसमें था carbidopa inhibits the dopamine receptor. Instead of this, carbidopa inhibits the dopamine receptor. So obviously this would be a wrong statement then. So if it is dopamine receptor, this was the option. So A is the direct answer. So carbidopa inhibits dopamine receptor. This is wrong statement. Option A would be correct in case this was there, right? Now I'm trying to going fast, but I also have to correct the options also. The purpose of this discussion is to recall the options, recall the questions which were asked in the exam. या तो इस क्वेश्चन में हार्ट ब्लॉक का पेशेंट था एंड दे आर आस्किंग व्हाट इज द बेस्ट ट्रीटमेंट सो आंसर इज एट्रोपिन so atropine is the best medicine for heart block. So this is also, again, I would like to take credit because this was directly taken up from our notes again. हाँ तो डायरेक्टली देखो ना ये क्वेश्चन आया ये रहा. So we have written in our notes that atropine is drug of choice for sinus bradycardia and drug of choice for heart block. So during our lecture also ये क्वेश्चन ना last time NEET में आया था. This was a NEET 2025 question. So your dental NEET 2025 question. This was based on basically the bradycardia. तो bradycardia पूछा गया था 25 में. Heart block they have asked in 2026. So we specifically mentioned during our lecture that atropine is the best medicine for AV block, heart block. So again taken directly from our notes. So you can see like most of the questions have come from our notes only. So question number 10 answer is atropine of this MCQ. ये heart block का treatment पूछ लिया. Question number 11. Question number 11 they have asked you the benzodiazepine's toxicity. So benzodiazepine toxicity का antidote. So this is directly from our notes flumazenil. So flumazenil is the antidote of choice for benzodiazepine toxicity. So patient has taken benzodiazepine, patient has got toxicity. Which medicine is given to reverse the symptom? So which medicine is given to reverse the symptom? Answer is flumazenil. So flumazenil is antidote of benzodiazepine. Again taken directly from our notes. You can see from this page number 85. Page number 85 of our notes, benzodiazepine toxicity. You can see benzodiazepine toxicity, flumazenil is an antidote of choice. So flumazenil is antidote of choice, right? So this is the direct question taken from our notes, right? Okay. So question number 11, flumazenil was the answer. Okay. Now moving on to question number 12. During the extraction of teeth, patient developed PSVT. So this was asked in your November 2025 NEET also. The patient has got PSVT. How will you manage the patient on outpatient basis? The hospital में adenosine is given by IV route. So it's a drug of choice given by IV route. According to some students, इसमें ऐसा option था कि patient has come to you with acute symptom and you have managed the patient in hospital. So patient has come to you with acute symptom and you have already stabilized the patient. The patient is already stabilized in hospital. And once the patient is stabilized in hospital, which medicine is given? Which medicine is given on outpatient basis? I think this was the question. Yes, prophylaxis पूछा था. Okay. So instead of हाँ तो outpatient question था. तो outpatient means they have asked you the prophylaxis. So prophylaxis में verapamil is the answer. So verapamil is the drug that is given by oral route. So prophylaxis is given by oral route, right? So adenosine given by IV route. Dr. Harshita, adenosine पहला option था, first option था. Students have told me कि adenosine they have given as a first option. So prophylaxis means the outpatient basis. तो ये question है actually this was asked in the NEET medical side. So medical side पे NEET 2025 का question है ये. This was asked in 2025 NEET exam question कि outpatient basis पे which medicine is given by oral route, and we discussed this point already so many times during our lecture that verapamil is the answer. So verapamil given by oral route, right? So we have discussed this point in Arjuna batch also. We have discussed this point during our lecture also because I told you this was asked in NEET exam, can be asked in your exam. This was the NEET medical PG 2025 question. Verapamil was the answer. So again, I have taken the reference that verapamil is the medicine. That's the second drug of choice for PSVT, and this is the drug of choice for maintenance treatment of PSVT, right? Now, next question is, this was the question. Patient has come to you with, patient has got a sudden facial swelling, breathlessness, and some contrast agent was given. So this is a case of anaphylactic shock or anaphylaxis, and they are asking you which medicine is the best medicine for anaphylaxis. Right? So anaphylaxis ka best treatment they have asked you, and this was the intramuscular epinephrine. 0.5 milligram is the dose given by intramuscular route. So intramuscular epinephrine 1:1000, 0.5 milligram. This is also directly taken from our notes, right? Also taken directly from our notes. So this was the question, anaphylactic shock mein. This was the treatment of choice for this condition. We have discussed so many times during our lecture also, right? So intramuscular epinephrine is the best answer for this question, right? Best management तो बच्चे यही है. This is a supportive treatment. This is the supportive treatment. Best management is intramuscular epinephrine is given to the patient. Okay. Now next is a patient presented with paresthesia of the tongue and lip after extraction of the mandibular third molar. ठीक है, तो बेसिकली हुआ क्या, यू हैव डन सम सर्जरी और सर्जरी के बाद पेशेंट हैज गॉट दिस बर्निंग पेन, burning sensation or pain. So this is a traumatic injury. So patient has got traumatic injury to the nerve. So traumatic neuronal injury. So this is a nerve injury caused by the surgery. Now which medicine is given? So which medicine is given? Answer is pregabalin. So pregabalin is a drug that is given for traumatic injury. Carbamazepine is given for trigeminal neuralgia. So this medicine is given for trigeminal neuralgia. So it's not a case of trigeminal neuralgia. This is not the case of trigeminal neuralgia, right? हाँ, तो यहाँ पे कार्बामेजेपिन इज नॉट यूज. कार्बामेजेपिन इज नॉट गिवन आफ्टर ट्रॉमेटिक इंजरी. सो ट्रॉमेटिक न्यूरोनल इंजरी वी डोंट गिव द कार्बामेजेपिन, वी गिव प्रीगाबालिन फॉर दैट. सो आंसर इज सी, राइट? तो इसमें ये डाइक्लोफेनिक का ऑप्शन एंड ट्रामाडोल ऑप्शंस वर देयर. डाइक्लोफेनिक इज एनेस्टेट गिवन फॉर इन्फ्लेमेटरी पेन. Tramadol is opioid. This is given after some visceral pain. So answer is pregabalin. Question 14, answer is C. Now this is again taken from our notes. You can see neuralgia के treatment में we have told you that pregabalin is a better medicine. So pregabalin medicine we have discussed. Although we have not discussed this question in this way, obviously whenever we teach you anything, the questions can be twisted. The language of the questions can be twisted. But whenever we teach you anything, you should understand the concept, and accordingly you can mark the answer in the exam, right? Now, the last question, question number 16, I think the second last question. A patient has undergoing the short duration anesthesia. Short duration anesthesia appears awake with eyes open, exhibit hallucination, delirium. So this was a question from anesthesia drugs actually. So anesthesia drugs, we people take the separation for anesthesia drug for you people. So here the answer is ketamine. It's a dissociative anesthesia. It's a dissociative anesthesia. Previous question में trigger zone था. They mentioned the trigger zone. Okay, guys, can you please tell me the language? Kya language tha? What was the mention the trigger zone and the tingling pain? So this pain was given as a tingling pain. So this is a neurological pain. So tingling pain means neural pain hai. It's not an inflammatory pain. It's not the pain because of stress. And trigger zone, there was a trigger zone mentioned. Like what was the language? What was the language actually? So can you please tell me the language? Or this question was based on? This question was based on trigger zone was exact statement was light touch on pain. Infection was there. Okay, do one thing. If infection was there or not there, because this question seems to be the language seems to be highly incorrect. So guys, whatever be the language, I required the full exactly what was asked in the exam, because all these are painkillers.
Good afternoon, sir.
Yeah, Dr. Himani, can you help me out?
This is the exact language of the question, and in my opinion, from oral surgery point of view, also you are absolutely correct. Pregabalin was the thing that examiner was wanting to ask कि भाई
Okay.
जब न्यूरालजिक पेन है बट नॉट न्यूरालजिया, नॉट ट्रेजमल न्यूरालजिया, जब वो रेसिडुअल पैरेस्थीसिया रह जाते हैं आफ्टर इम्प्लांट सर्जरी और आफ्टर एनी थर्ड मोलर सर्जरी, it is pregabalin what we prescribe day in and day out. So you are absolutely correct here. This is the exact language of the question, and these were the options. And
Chalo.
even I feel that pregabalin is the best answer here.
So confusion is clear. The expert has given the opinion. So all doubts are cleared now, right? So now the last question, question number 17. The question number 17, which of these drugs is used for conscious sedation? And by the route given below, it's a nasal route. You can see the medicine is given by nasal route. And these were the options. Answer is midazolam. So midazolam was the answer of this question. And this is again taken directly from our notes. You can see we have discussed this point that midazolam is taken in the form of nasal spray. So midazolam is taken in the form of nasal spray. It's a very convenient method to give medicines to our patients. So midazolam can be given by nasal route. So this was the answer. So you can see most of the questions have been asked from our notes only. Right? Yeah, thanks guys. You were giving me credit for this, but it's not because of me. I just showed you the path, like how to solve MCQ. It's all about your hard work. You people have done so much of hard work. That's why you are able to solve most of the questions of pharmacology. And I'm really proud of you. And with this, I'm handing over to this session to the next educator. So Dr. Himani, is this your session?
Yes, sir. I will be taking the next oral surgery questions now.
Okay,
I was
chalo,
just
good.
watching your session, sir, and I'm very, very proud that almost every question that you've discussed, which is there from our notes, and I'm seriously congratulations to you, sir, for doing a very good job
Thank
this
you.
year with the students.
Yeah, thanks. All the best to all of you. Okay, bye.
All right. Thank you, sir. Thank you so much. And good afternoon, everybody. Welcome to the oral surgery recall questions. I will just quickly join the YouTube also so that whatever questions you have, I can answer. Okay. All right. All right. Thank you, sir. Thank you so much. And good. Okay. Okay. So let us begin with the oral surgery questions. Can you all see the screen here? Are you all able to see the screen? Okay, I think it is visible now. Okay, all the complications seen in the image below occurs due to diffusion of local anesthetic solution into the adjoining soft tissues. This is seen most commonly with which nerve block? I am sure all of you have marked this correctly. It is because of the LA solution going into the parotid gland. And which nerve do we have in the parotid gland? In the parotid gland, we have the facial nerve. And when there is a unilateral facial nerve palsy, the patient will have this kind of a look where her eyebrow lifting, her nasolabial fold, her smile, everything becomes asymmetric. Right? And this happens when the facial nerve is involved. The only nerve block which can cause, instead of the needle touching the lingula of ramus and depositing the solution for I and B, it can go backward. If you know, from final years, we have been listening that you should touch the bone when we are doing inferior alveolar nerve block. And this is the reason. If you don't touch the bone, you're going too posteriorly, you will enter into the parotid gland. And the nerve in the parotid gland is the facial nerve. So this is seen with inferior alveolar nerve block. We have taken it in our complications of local anesthesia in the local anesthesia chapter, and in detail we have discussed about facial palsy caused by the inferior alveolar nerve block. All right, I'm very happy all of you are marking B here. All of you have marked B, which is the correct answer. Another question, the image below shows problem in which of the following nerves? Now, like I've said yesterday in my analysis also, a lot of repetitive questions were there. Like pharyngeal arch questions were repetitive. Thyroid questions were very repetitive with slightly different options and answers. Anemia questions were very, very repetitive. Similarly, the examiner was in love with the facial nerve, or maybe somebody in his house would have got a Bell's palsy and all the paper was full of facial nerve. So this is another very similar question that, these three areas are affected. You can see the temporal, the zygomatic, and the buccal branches being affected. So obviously it is the facial nerve. Again, a direct pick from our notes. We have taken this in detail in the pathology section also, that any pathology seen, if you see here, it's written any pathology, surgery or procedure or trauma done near the parotid area will affect the facial nerve. All right, and it may cause a temporary facial nerve paralysis. You can see we have even used the exact image. Okay, this is actually one of my patients, which I have seen, but we have used this image in our notes, and very similar image was there in the exam also, where you can see the nasolabial fold is present on one side and absent on one side. It is present, smile is symmetrically present on one side and absent on the other side. Eyebrows will be raising on one side and not on the other side. This is how it resolves. All right, so again, a direct pick, thankfully, from our notes, and I hope all of you were correctly answered this question. Somehow oral surgery questions were not very tricky and most of them were straightforward. Next question, 58-year-old female, submandibular submental swelling, raised floor of mouth, fever, white cell count is increased. So clearly a case of sepsis secondary to Ludwig's angina. And we know that in the treatment of Ludwig's angina, before you do incision and drainage, you're supposed to do establishment of airway, because if you put a cut there, already this area is swollen. If you put a cut and drain, yes, it will drain, but it will worsen the inflammation. So there is a further risk worsening in your airway. So the correct answer is A, Ludwig's angina. Again, a direct pick from our notes. Somehow this is blurring. I don't know why it is blurring. So Ludwig's angina, bilateral involvement of the submandibular, submental and sublingual spaces. The image is also the same which we have taught to you, right? And it's a surgical emergency where airway establishment followed by tracheostomy, oral intubation or tracheostomy followed by incision and drainage is the protocol. Okay, if this is a little blurred, you can go and check page number 75 of our notes and it is very clearly given there. Okay, so this is question number 3. Coming to question number 4, some of you might have made a mistake here. The space involved in the image which is marked by the arrow. Some of you have missed this part of the question marked by the arrow because you have seen two spaces. You can see the buccal space involved here and you can see the infraorbital space, which is also known as the canine space, right? And this is exactly the image which is there in our notes where we have shown you the canine space infection. All right, from the canine, the infection goes into the infraorbital space and give this kind of a puffy picture around the orbits, right? So this is nothing but the canine space, also known as the infraorbital space infection, right? I'm sure most of you have marked it correctly, but some of you, those who have missed this marked by arrow, maybe you have marked buccal. Yes, buccal is there, but that was not marked by the arrow. All right, so canine space. Okay, next question. 15-year-old girl presented with severe bilateral TMJ ankylosis with maximal incisal opening to be 0 mm with history of snoring, observed apnea. At sleep, image showed reduced posterior facial height, steep occlusal and mandibular plane, and reduced posterior airway space. All right. All this story is actually just the last line of the question, which is important. Which of these is the cause of development of OSA in a case of pediatric TMJ ankylosis? All right, like I said yesterday also, they've unnecessarily made the question too long, maybe to distract you or what, I don't know. And a very similar image was there in the exam, even worse, more severe than this one. And this is the image from our notes where, we have told you very clearly that restricted mandibular growth cause reduced tongue space and occlusion of the upper airway slip in space in sleep. I am very proud to have taught you this in two places. I have taught you OSA in the TMJ ankylosis part also, in the TMJ chapter also. And we have taught you OSA separately also in the miscellaneous section. All right, where properly I have made handmade diagrams and the anatomical factors which can cause obstructive sleep apnea is first one micrognathia or retrognathia. And in so much detail, we have talked about how the normal position of mandible will cause an open airway, whereas a retrognathic position of mandible will collapse the airway miserably, causing obstructive sleep apnea. It is not just mandible, but multiple anatomical obstructions that can cause it. But for us, primary is mandibular retrognathia or micrognathia. And in very much detail, we have taken it with radiographs, we have taken it with airway, posterior pharyngeal airway x-rays, we have taken it with PSD findings, we have taken it with diagrams. So I'm sure all my students, yes, Priya, Dipyan Mehta, you are absolutely correct. This is the correct answer. Okay, a patient presented with swelling in the left side of face, which is proliferative. Now, before I read this question, right, whenever we have an image-based question in the exam, the first thing that happens is our eyes will go to the image. Okay. Honestly, this X-ray, we are not able to find that the X-ray was actually even bigger and it was involving maxilla also. I was trying to find an image which is similar to the one in the exam, but this is the best I could find in short time. The actual image was the same image, but it was involving mandible with more expansion and maxilla also, right? So it was a multi-bony kind of a presentation. So bang on when I see this question, the first thing that comes to my mind when I see two bones being involved is ABC. But as soon as I read this increase in parathormone levels, hypercalcemia and increased SAP, serum alkaline phosphatase, I close my eyes and I will mark brown tumor. Very good, guys. Sanjana, Preetam, Saloni. Ameloblastoma. No, this is not ameloblastoma, beta. But all of you who have marked B, Happy Diaries, Namrata S, Kirthang, and Deepriya, very good. You are absolutely correct. See, I have taught you previously also that, all giant cell lesions. So these are all giant cell lesions, right? There are 4 giant cell lesions: central giant cell granuloma, hyperparathyroidism, which is presented as brown tumors, aneurysmal bone cyst, which can exist singularly or it can exist with other pathologies. Like, for example, ABC can be there within a CG, ABC can be there within a fibrous dysplasia also. So it's a coexisting pathology also. And fourth one is cherubism, right? Why I love talking about giant cell lesions is it's a very intriguing phenomenon. All these 4 pathologies have the exact clinical presentation, have almost similar radiographical presentation, and almost similar histological presentation also. It is only that minor histological difference is going to differentiate between CG, hyperparathyroidism, ABC, and cherubism. All right. Now, when you are treating it, the treatment of all the 4 is absolutely different. The treatment for CG is surgery. The treatment of hyperparathyroidism is endocrine management. That means you control the hormones. The treatment for ABC is nothing. You just have to do a resection, or just within the pathology, you can wait and watch. And the reason for cherubism is wait and watch. So imagine such a beautifully made body where giant cell lesion disease is there, presenting in 4 different forms, looking very similar radiographically, clinically, histologically also, but treatment is absolutely different for all lesions, right? Which is why the differential diagnosis of giant cell lesions becomes a very, very, very important thing. And again, I'm very happy that in our notes, we have taught it in much detail that hyperparathyroidism or brown tumor, you can judge when there is PTH and parathyroid related protein increased levels in hyperparathyroidism. So as soon as you see a giant cell lesion which says that it is increased PTH, close your eyes and mark brown tumor. All right, just mark brown tumor. All right. And we have also given you this differentiation that the final diagnosis between CG and hyperparathyroidism is done by the parathormone assay. That is the parathyroid hormone levels. So if the levels are normal, it's a diagnosis of exclusion, right? CG is a diagnosis of exclusion. So when the parathormone levels are normal, it is CG. When the parathormone levels are raised, it is hyperparathyroidism. All right, I am overwhelmed by the love that you guys are showing on the chats. And sorry, Sandalwoods, if I'm very fast, I will just slow down. Okay, I will just slow down a little bit. So till now, is it clear? Till now, everything is clear. Everything is clear till now. Everybody, just tell me, just give me a thumbs up if everything is clear. I will just slow down. I will just wait for you guys to catch up and tell me if it is clear. Till now it is clear. Okay. Thank you, Jyoti. Thank you everybody for letting me know. Okay, I will get a little slower. This question is also there in our notes in the form of a PYQ. So PYQs we take as separate PYQs in the app also, as full paper or as individual PYQs in individual subjects. PYQs we have also taken within our notes. So, our notes are foolproof. If you read the notes, you don't need any other book or any other thing for your preparation. So this exact question is there as a question form also in our notes itself, right? So central giant cell granuloma clinically and histologically resembles a brown tumor of hyperparathyroidism. How will you differentiate between CG and primary and secondary hyperparathyroidism, right? And the answer is parathormone assay. So if you read this question, if you know the concept behind it, you will be able to answer that, in this question, the correct answer is brown tumor, which is nothing but hyperparathyroidism, right? I hope this is clear with everybody and you have marked it correctly. So those who are not here to study, you can please leave, because this platform is to study. It is this platform that a lot of students have used for free, who are not able to afford the fees. They have used this same YouTube channel for free, and they have reached none other than AIMS New Delhi doing oral surgery. You can watch their interviews, who are now getting a stipend of almost 1.5 lakh a month, and you can watch their interviews. They have not taken our package, but it is through these free YouTube channels that a lot of students have learned and reached places like AIMS Delhi, right? So if you are not here to study and if you're just here to look at the answers, you can very well leave and just watch it in a 2x speed later on. All right, so don't be rude here in this session. We are all here to teach and learn. If you want to be rude, it's not a good thing, right? Okay. Next question, as per View's classification, the cleft involving the hard and soft palate up to the incisive foramen. This is honestly a PYQ. This has been asked multiple times before also, and we all know the correct answer is group 2, right? Again, direct pick from our notes. We have shown you that View's classification is a posterior to anterior classification, palate to lip classification. So it starts from the back. It starts from the soft palate and it goes ahead and it comes to the lip. Usually the classifications of cleft start from lip and go towards the palate. View's classification is the very few ones which start from the palate and come forward, right? So class 1 is soft palate only. Class 2 is soft and hard palate up to the incisive foramen. Class 3 is complete unilateral and class 4 is complete bilateral, right? So this is a PYQ. Group 2, most of you have marked group 2, which is the correct answer. Okay. Next question again from cleft. So this time I was pleasantly surprised to see that there were no questions from trauma, no questions from exodontia, but 2 or 3 questions from distraction and cleft, which is not very, very common in NEET. Yes, in INI they were asking, but this time in NEET also they have asked. So all those who have studied properly, I'm sure you are at very big advantage in this NEET exam. All right. Okay. Which of these is a complication that can happen with untreated cleft palate? And I'm very happy that all of you have marked B, which is the correct answer. Otitis media and hearing defects. Hemlata, Preetham, Abinjos, Harshal, all of you are absolutely correct. Okay. Rampant caries, there is no problem with mouth opening. So this usually happens when the mouth opening is decreased, like TMJ ankylosis. So this will not happen in cleft. Yeah, so mouth opening is not a problem. Maxillary constriction and hypoplasia. This happens in treated cases of cleft palate, not untreated. So when you treat the cleft palate, after the surgery, there is a scar. There is a scar. And that scar causes maxillary constriction, right? Because of that surgical scar, there is constriction of the maxilla causing reduced width and reduced anterior-posterior dimensions of the maxilla, right? So this will happen if the cleft is treated, right? This is untreated cleft palate, okay? So this is not going to happen. And the last one is mandibular protrusion. So why will mandibular protrusion happen in a patient of cleft, right? Cleft is a disease of midface. So correct answer is clearly otitis media and hearing defects. Once again, directly from our notes, in the cleft chapter, we have discussed what is the need for correction of cleft. Why should we correct, right? So growth disturbances, speech, nasal twang in speech, occlusion. Fourth one is ear infections, recurrent ear infections leading to hearing loss. Absolute pickup from the notes. So straightforward, you have answered it absolutely correctly. Okay. Next one, again, this was actually asked in part A, but I stole this question from Saurabh sir's part because here LA we are primarily teaching both in pharma and oral surgery, but there were very few questions in oral surgery and many questions in pharma. So I told Saurabh sir, mujhe kuch zyada questions de do so I can talk with students more, right? So the effect of local anesthetic solution after inferior alveolar nerve block is reduced. In the case of an abscess, what is the cause? This is also a direct PYQ, which is asked previously, and we all know the answer, that it is due to reduced dissociation of the unionized form of the drug, right? We have taken this in our notes and our lectures where we have shown you the effect of acidic environment in the LA, right? So the tissue pH is governed by inflammation and pus. Whenever there is an inflammation and pus, the pH will decrease, right? When the pH decreases, the RNH plus, which is the solution of LA, which should ideally dissociate into RN and H plus. And this RN will go into the nerve, right? So the unionized form has to dissociate and become ionized. And then that solution can go into the nerve and cause its effect of anesthesia. But in case of already decreased pH, what is the meaning of decreased pH? Decreased pH means there is an acidic environment, right? And acidic environment means there is a lot of H plus ions already in the tissue. So when already the tissue has a lot of H plus ions, why should this molecule dissociate? It will dissociate only when there is no H plus molecule or reduced H plus molecules, right? So whenever there is inflammation or pus, because of reduced tissue pH and excessive H plus ions in the tissue, this local anesthetic solution does not dissociate only. Because it doesn't dissociate, it is not able to penetrate the nerve, right? So that is again from the notes, and I'm sure you have all marked it correctly. Okay, so this finishes all the questions of oral surgery, and pH must be there. Okay, reduced pH would be there in the question, but still the answer would remain the same. Okay, and I hope till today's recall, you have found a lot of questions that you have done correctly. Maybe there are some questions which you have done wrong. Please, guys, again, I'm saying, don't worry about these questions. Okay, even the first ranker will have around 15, 20, 25 questions which are wrong. Okay, it was a high marking paper. Students have marked a lot because the paper was such that you will tend to mark. Even the difficult questions like anemia questions or micro questions, they also felt like kahin to bhi padha hai. We have seen this somewhere, we have read this somewhere. So the attempt is very high this time. And whenever the attempt becomes high, the negative marking is also high, right? So don't worry if you have made mistakes. Everybody has made mistakes. It is absolutely okay, right? Don't let this recall affect your INI-CET exam in a negative way. Learn from this recall. If you have made some mistakes, go back to those questions which are wrong, study them from your notes again, so that if in case they are asked in INI-CET again, you should not make a mistake now, right? That is the purpose of this recall, that in next 15 days or rather 14 days, we have another very big exam. So go back and correct your answers. Don't let this affect your preparation. Okay. Thank you so much. We will finish our mega recall session here today with oral surgery. I know you were promised a few more sessions today, but we will be taking all the remaining subjects tomorrow because we don't want any imperfect questions or images to reach you. We are finalizing with those subjects, and tomorrow all the pending subjects recall we will take. All right. If you have any feedbacks, you can give it to us on our DBMCI MDS groups on Facebook and Telegram. There's an open DBMCI MDS Premier group, Telegram Premier group, which is open for all students. If you have any feedbacks, any messages, or any doubts, any queries, you can share it with us. All right. So all the best, beta. God bless you all. And we'll see you tomorrow again in the mega recall session. Thank you so much.